Today, I am honored to introduce you to Dr. Danielle Belardo. Danielle is one of the nation's leading cardiologists. Don't do it. I know you're one of the nation's leading cardiologists, chair of the American Society for Preventive Cardiology's Nutrition Committee, and is one of the most brilliant, articulate, and passionate individuals I've ever met. Danielle is the founder of Precision Preventative Cardiology, an outspoken advocate of blending cutting-edge medical strategies with practical lifestyle changes like diet and exercise. She loves animals, has an adorable dog, and is a fierce proponent of rescuing animals from shelters. Danielle is someone I will reference when my daughters are looking for inspiration as they get older, and I am blessed to have her here with me today. Dr. Danielle Belardo, welcome to the podcast.
That is too nice of an intro. I'm so happy to be here with you. And for anyone listening, Jordan's been a huge inspiration to me too. He's the reason why I got into strength training. And I've just loved following your work for years. So I'm so happy to be able to do this with you today.
The feeling is mutual. We're going to start off. Who are you?
So that was a beautiful intro. But yes, I'm Danielle. I live in Los Angeles. I'm a preventive cardiologist. So I focus on cardiovascular disease prevention, cardiometabolic health. So things like hypertension, weight management, as well as primary prevention of cardiovascular disease, as well as secondary prevention. And I also have a big focus on evidence-based medicine and trying to hopefully empower people through social media to understand how to look at scientific evidence that's presented to them and evaluate it critically and be able to navigate the wild world of, health information that's online these days.
You do an incredible job of it.
Well, thank you.
If you're not following Danielle, please go do that right now. We'll put her social media handles all over in the show notes and everything. What misconceptions do you think people have about you? Maybe they stumble across your social media. What do you think they have? What misconceptions are there?
Well, I think it probably back in the day, some of them were deserved. So, you and I have talked about this. I'm vegan, and I've been vegan for years and years and years. But I've actually really had an evolution. The more evidence-based I've become, which really took a lot of effort. So, I feel like I had what I think is a really valuable journey in what I call my journey through evidence-based medicine is understanding what's called critical scientific appraisal. So understanding how do you evaluate a clinical study and know whether or not this is a valuable study with valuable endpoints. And the reason why I think it goes into the misconception is about me, which was previously deserved, is that I probably was maybe a decade ago a bit of a dogmatic vegan when it came to nutrition science. And then when you go through medical training, 4 years of medical school, 3 years of internal medicine residency, 3 years of cardiology fellowship, I'll never forget showing up to Journal Club when I was a cardiology fellow, thinking I had all the answers, and bringing a research study by Dean Ornish that showed that you can reverse cardiovascular disease with a plant-based diet, and having these brilliant cardiologists who've been working in cardiology for decades look at me and say, you need to learn how to read and critically appraise a research study, because the fact that you brought this study shows us that you actually don't know how to evaluate scientific evidence. Not every study that's a randomized controlled trial is showing you what you think says, or what the abstract shows. And then when you actually deep dive into that study, you'll see that it doesn't show that you can reverse coronary artery disease at all. It doesn't show that what you think it does or what it says in the abstract. And so I started to actually question things, because I'd say wait, then, why am I telling patients they can reverse their heart disease with the diet? And I was only in training at the time. I wasn't an attending physician yet. And so then I thought, oh my gosh, I owe it to my patients and to myself to really focus on learning critical scientific appraisal. And I think that one other real motivation for that is I'm the only doctor in my family. I don't have any cousins who are doctors or aunts or uncles. And when my niece was diagnosed with leukemia when I was probably about 8 years ago. She's now 5 years in remission.
Thank God.
Thank you, God. And so I realized, oh my goodness, there's so much misinformation out there that, thank God, she's doing amazing because of guideline-directed medical therapy. But I saw my sister and her husband, who are incredibly intelligent, ask me, well, is this true? Is this supplement true? Is this diet true? And it really just put a fire under my butt to be the best scientist and physician I can be. And I always say I don't work, in industry or anything like that. My only loyalty is to the science and my patients. And I think that the biggest misconception probably previously about me was that I was dogmatic about nutrition. But I think over the last decade, I have completely evolved, where now I'm a vegan, of course, still vegan, for ethical reasons. But I know from the scientific evidence, when we published our 2022 clinical practice statements for the American Society of Preventive Cardiology on heart disease prevention through diet, atherosclerotic cardiovascular disease, and nutrition advice, I was the lead author. And it was the biggest honor because my co-authors on this clinical practice statement are the top cardiologists and nutrition scientists in the world and people who I've admired, throughout my training. And as you come to a consensus statement like that and you go through thousands of studies, we know that, yes, eating a healthy, well-planned plant-based diet is helpful, but so is a healthy, well-planned Mediterranean diet. And there's many ways you can make a dietary pattern very healthy. And so that's kind of the long story of my evolution and a previous misconception that I hopefully have over the last decade changed.
I know you have, because I remember after the last time you and I recorded a podcast together, one of the comments I got was, I was nervous to listen to this because previously I've seen Dr. Belardo being dogmatic, but it looks like she's so open-minded and she's changed her stance. So it's definitely made an impact.
And don't you think, to me, actually, I think and I feel like you've done this too. I think that what's really amazing, not that you've been dogmatic, but I think
I've been dogmatic.
But what you've done is been willing to change your mind about something.
Yes.
And I think, to me, that is my best quality. I think it's not that I am the best doctor in the world or the best XYZ in the world. It's that I am willing to learn and to evaluate scientific evidence, and learning critical scientific appraisal is such a huge part of that. Understanding how to evaluate research study and grade and systematically review research is such a huge part of that, because now I view, the reason why guidelines exist is because there is no one arbiter of truth. There is expert consensus exists because you have multiple people who dedicate their lives to critical appraisal, who then join forces to evaluate levels of evidence in a systematic way. And I think that being able to change your mind when you're presented with good evidence or understanding why levels of evidence exist is really, to me, just a great quality for all of us. Because I think, I look back at my old dogmatic self and I say, you know what? It is what it is. I learned from it. And I think the most important part is not where you were, but where you get to, and being open to change.
So aside from your views on plant-based diets for everybody, what's something you used to believe but you no longer do?
It's probably my biggest one, because that shook me up a lot. And so that shook me up, and I was like, wait, what do you mean this trial doesn't show what I think it shows? I've had to be very I learned a lot about evidence-based medicine, actually, because you learn about it during training, but not as deep as you want. That's why not every physician is going to be on the guidelines. Not every physician or scientist is going to be focused on critical appraisal. It is not literally what's for everyone, right? That's why we have guidelines. So that way you can practice medicine and have a rubric to go through. But I will say that what it changed me looking at the most was that it made me then say, take a real big step back and do an inventory on everything and say, okay, how do I learn about evidence-based medicine? And also approaching things with uncertainty. I think that one thing doctors, and especially social media communicators, whether they're a physician or in health science, people have difficulty expressing uncertainty. And actually, sometimes the most evidence-based thing to do is to explain, this is a data-free zone. We don't have the answer to this. And that, to me, has been a good guide moving forward to not be overly confident with things, and, kind of explain that science is dynamic. It's a living organism, and it's changing.
I have a section, it's labeled "You Said." So I'm going through some things that you've said on social media.
Oh, boy.
And I want to talk about them, okay?
Oh, God. Okay. Is this a torture chamber?
No. So it's all good stuff.
Okay.
You said, and by the way, I put the word bullshit in there, even though you didn't say bullshit in this, but you said parasite cleanses, adrenal fatigue, and powdered green supplements like AG1 are pseudoscience bullshit. I plugged that in there for you.
I would agree with, I would concur with bullshit. Correct. I stand by that.
Considering you're, in my opinion, one of the nation's leading cardiologists, I want to hear why. So let's go through each one individually, starting with AG1. Why is it bullshit?
So I would say, so on the spectrum of things in pseudoscience, and this is actually like a rubric people can use. It's almost like you don't need 8 different rubrics to evaluate a pseudoscience. You can kind of, one of the biggest tools, I think, is looking through everything from a critical lens and saying, okay, can I apply this same kind of framework for everything that's confusing? Because there's always going to be a headline for something, and you're always going to find a study that's on PubMed, maybe in a mouse, maybe in a human, that shows what you think it should show that, and maybe it doesn't fit with scientific consensus. So with regards to AG1, when it comes to benefits versus risks of something, this is something you and I have discussed, how that's a constant evaluator in my mind when I'm having discussions with patients or with public health. So what are the benefits of having a something like a powdered greens of any kind? There's so many different brands, and we know that even when we wrote our clinical practice statement for the American Society of Preventive Cardiology on nutrition and cardiovascular disease prevention, that if supplements were so powerful and so impactful, that would make our job a lot easier, right? Mm-hmm. But we actually know that the health benefits that come from eating greens, eating fruits, vegetables, whole grains, legumes, nuts, seeds, this is not just from the individual extracted contents. It's not just from the fiber itself. It's not just from the polyphenols itself. It's from the entire package. And so we know that when you're supplementing it, it doesn't translate into those hard outcomes, that reduction in cancer risk reduction, cardiovascular disease reduction, and all these things. So in general, what we say about things like powdered greens is just eat the food, save your money, eat the fruits and vegetables, and you don't need to buy it in that form. It's a little less sexy, right? When I tell patients, you can buy frozen fruits and vegetables or canned. There's the same nutrient density in them. You can go to Costco. You don't need to buy organic. These are things that are true based on science, but can sometimes be hard to hear because of how much of the misinformation there is on social media. And sometimes when things are packaged and marketed in a certain way, it's appealing. Mm-hmm. But sometimes the actual truth is cheaper, but also less fancy.
AG1 and really any powdered green, it seems to me like a very overpriced, outrageously expensive, shitty multivitamin. Right? Whereas, number one, if you want to take a multivitamin, you could probably get a better one for way less expensive.
Sure, yes.
And from what it sounds like you're saying is the benefits, like they're highlighting all the vitamins, the minerals, all that you get within the packaging.
Right.
But what you're saying is that's not what gives fruits, vegetables, food the benefit. It's not just the micronutrients. It's the whole package.
It's the whole package. Same thing with fiber supplements. That's why we say when we want you to increase fiber in your diet, it's from foods, not from supplements. And that's because it's probably twofold. One is because it's not just the fiber itself, or it's not just the vitamin C itself. I mean, how many vitamins have been studied, right? Mm-hmm. Outside of deficiency, this is something I've been quoted on social media saying a lot, but I can't find a better phrase for it. But I always say that outside of deficiency or outside of a guideline indicated use for a vitamin, so if you're vitamin D deficient or you live in a certain region, geographic region, or B12 if you're plant-based, or folic acid for women of childbearing age, there's certain guideline indications for vitamin repletion, as well as outside of deficiency. Vitamins and supplements are usually expensive urine at best, and they can cause end organ damage or damage for your kidney, liver, arrhythmia, heart damage at worst. And so that's why it's the reason why it's when we look at things like green powders, or if you look at fiber when it's in a supplement form, the reason why it doesn't translate to the same clinical outcomes as the food is because there is no placebo when it comes to nutrition science, because we all eat, right? But when you look at the hard outcome trials, so things that matter, like reduction in cardiovascular endpoints like heart attack, stroke, cardiovascular disease, or even if you're looking at biomarker data and things like that, when you are eating foods that are high in fiber, of course, they're high in fiber, which helps to lower your cholesterol and can help lower blood pressure. It's also packaged with all these micronutrients and things like that, but it's also the food that it's replacing. And that's where people forget, right? So when you're eating more legumes and greens and fruits and vegetables, these foods have more water content, more volume. They're naturally going to displace something else that may be less beneficial for you. And so it's kind of a twofold. And that's why it really is the actual food that's more beneficial rather than just the individual nutrients themselves.
Before we move on to parasite cleanses and adrenal fatigue,
It's a good one.
I want to ask because you're already talking a lot about fiber, which you and I are
Yes.
both like
Team fiber.
team fiber. Can you explain? I feel like people hear it, but they don't understand what it does. They don't
Yeah.
understand the difference between soluble, insoluble.
Yeah.
Can you explain what does fiber do, the differences in the types of fiber, and we'll just go from there.
Absolutely. So there are different types of fiber. There's soluble fiber, there's insoluble fiber, specifically viscous fibers, which are most associated with lowering cholesterol. But I tell patients, don't even worry about the different fiber subtypes. Just focus on getting fiber from foods. And, we talk about, if you go on social media, you'd think that in America, we live in this land of a huge protein deficiency, which couldn't be further from the truth. I've never seen anyone with a protein deficiency that is a normal, healthy adult. But we have a massive fiber deficiency.
Huge.
We have a ton of research that shows us that we are not, the average American is getting maybe 10 to 15 grams of fiber a day. And the RDA for men is 38 grams of fiber a day. And for women, they say it's 28 grams. But I would definitely recommend more towards at least 38 grams of fiber a day as well. And so what's so fascinating is that why is fiber so beneficial in the form of whole foods? Well, one is, as I mentioned, the food it's replacing things with, because as you eat more of these healthful foods, you're going to be able to eat less of those maybe less healthful foods. And additionally, it works a multitude of ways. So when you look at nutrition science research, you're always looking at multiple levels of evidence. There's not going to be just one study generally that's going to make all of the recommendations. So you're looking at short-term randomized controlled trials that are tightly controlled, where people are living in a metabolic ward and every single thing they're eating is measured. But when you're doing that for 2 weeks, you're not going to see hard outcome data, right? Like heart attack and stroke. You're going to see immediate biomarkers, things like weight, things like blood work, blood pressure. Then you have longer randomized controlled trials that are free living, where you're looking at 2 years, 4 years, where people are randomized to a specific intervention versus a control group. And you're looking to see things that are actual heart outcomes, like heart attack, stroke, and things like that. And then you look at these long-term perspective cohorts where they're looking at dose. So dose and exposure to a certain amount of how many, what tertile of fruit and vegetable consumption someone is in, versus maybe red meat consumption. And from those longer term perspective cohort studies, you can deduce things like, well, what is the exposure to a certain variable or certain food? People have more exposure to eating, say, more fruits and vegetables and legumes and things like that, less red meat, to a longer term outcome, things like colorectal cancer, for example. And we know that increasing fiber in your diet reduces your risk of colorectal cancer and certain other kinds of cancers as well. And so the way it works specifically in cardiology is that we know that fiber helps to reduce your what's called atherogenic lipoproteins. So these are the cholesterol particles that essentially get in your vessel wall and cause coronary artery disease. So this is your LDL cholesterol and your ApoB, which are a little bit synonymous because every LDL particle has an ApoB lipoprotein on it. And your liver has no way to get rid of LDL cholesterol. So the way your liver does get rid of LDL cholesterol is it packages it into bile. And bile is a digestive enzyme which goes into your GI tract. And when you're eating a low-fiber diet, bile does its job, it digests things, and then it does something called enterohepatic circulation, where it crosses over, and then the liver picks it back up and does the whole thing again. When you eat a higher fiber diet, and the more fiber you eat, the more of an effect it will have, the fiber actually binds bile in your gastric tract, and then you poop it out. And then your liver says, wait, where's all my cholesterol? Where's my LDL cholesterol? And it has to pull more LDL cholesterol from the bloodstream in order to create more bile.
That makes sense.
And so through that mechanism, that's one way in which it helps to reduce your cholesterol directly.
What are some of your go-to high fiber sources for people?
Oh, this is one of my favorites. So there's so many, and I always tell people to experiment because what maybe my favorite high fiber sources may not be someone else's. But there's, there's the small switches that are easier for people to do, like switching from white bread to whole wheat bread, switching from white rice to brown rice. These are, I call them lateral switches that can be a lot easier, that don't feel like you're turning your life upside down. And then there's some fruits that are higher in fiber. You get more bang for your buck with, say, like raspberries and blackberries can have like 8 grams of fiber per cup.
Those are the best.
They're amazing. Apples have a great amount of fiber. I mean, all fiber only exists in plants, so you get lots of fiber in all different plant foods. Artichokes, avocados, high in fiber.
I love avocado.
Amazing.
Yes.
And we were talking before about legume pastas. So a lot of different legume pastas have tons of fiber. You can have like edamame and mung bean pasta. You can have chickpea pasta, lentil pasta.
And you're Italian and you're promoting this, so come on.
Yes, yeah. I love legume pasta because they're also super high in protein. So you can kind of kill 2 birds with 1 stone and get your high fiber, high protein at the same time. And legumes of every kind have tons of fiber. So lots of options. There's something for everyone.
You know what I do is, so I love lentils, beans and lentils.
Amazing.
What I recently found is these like pre-packaged lentils that I just take them out, rip open the bag, put it in the microwave, heat them up, and like they're good to go.
Love that.
We also just got, so the fitness crowd shits on me for this. I love juicing, like not like all day every day, but I love carrot juice with ginger.
Okay, gotcha.
I love like
Just extract the fiber. Why not smoothie it?
Well, no. So here's the thing. So I get enough fiber. Like,
oh yeah, you're a fiber king.
I eat plenty of fiber.
Yeah, so it's just a little
I'm
treat.
usually getting like 40 to 50 grams of fiber a day.
Yeah.
I just really enjoy carrot juice with ginger and mint.
What Jordan's telling everyone is, rather than a full calorie Coke, he wants a little treat of carrot juice with ginger and mint.
I love it. It makes me feel good. I start the day with it. It's great. But I got this juicer recently that has this like a sorbet function with it. So I take frozen raspberries, frozen blackberries, I put it in, and out of the pulp side, where usually the pulp goes, comes out a full-on like raspberry blackberry sorbet.
Yum.
And then I freeze I take Greek yogurt and I'll put that in there and freeze it, and then it makes it more creamy.
Amazing.
High protein, high fiber dessert. It's been amazing. My wife loves it. Yeah, super good.
Amazing. That's just awesome.
I'm all about trying to find ways to make getting fiber easier for people and more tasty, because I think a lot of people, they struggle with it. They just think, oh, like raw broccoli. And it's like, no, there's so many ways to make it more delicious. And
so many ways. And there's also, you do not have to like all forms of them. You can, people are allowed to not like certain vegetables.
Yeah.
I happen to love a lot of different vegetables, but you don't have to love Brussels sprouts just because, we may love Brussels sprouts. You can, trial and error is really key in finding things, because everyone's going to have a different taste.
Correct. Yeah. So tell me, why are parasite cleanses bullshit?
This is so funny. So, when like Instagram really blew up about functional medicine, which is, we can go into that for years about how that's just a marketing term and is not an actual scientific rubric whatsoever. But when functional medicine really hit the internet waves, and there was all these things about parasite cleanses, I remember thinking, wait a second, in my 10 years of medical training, did I like miss this wave of parasites? And so one of my good friends from residency is an infectious disease doctor at Emory. And I had talked to her about it, and she was cracking up because she's like, it's all, nonsensical. You talk to any ID doctor, any GI doctor, and they'll tell you, of course, parasites exist, right? So there's true parasite infections. People are traveling abroad and they may be exposed if their water's not clean, all of these things. Those are not treated with a parasite cleanse bought on Instagram. Those are treated with actual medications that are parasitic,
including like ivermectin, right?
That's well, it depends. There's for different parasites, different treatments. But I defer to the infectious disease doctors for that. But I know for sure it's not treated through these quote unquote cleanses. And then I found out something really fascinating. So then I found out from a GI doctor who mentioned to me that, and you know what they do with these parasite cleanses is they actually put a ton of like inulin or different kinds of fiber in them, so that when you have a bowel movement, you have this stringy bowel movement that looks like you excreted a parasite, but it's just what's in the powder.
They're really taking duping people to the next
level.
Giant
Giant circular scam. So yes, if you have a true parasite, you should go see an infectious disease doctor and get a prescription to treat that. And that it's not that that doesn't exist. It's just not common enough in my 10 years of medical training. I just happen to not see it. But if you work in, I trained in Philadelphia, but if you work in an area, I've had friends that are, ID docs in New York City that, someone's traveling from abroad and they come in and they have a parasite infection. It's not non-existent, but that is not treated with the parasite cleanses on social media.
Same thing with the detoxes that are promoted. Like, number one, it's funny when people are like, yeah, I'm detoxing. I'm like, what are you detoxing from? Like, which toxins?
Right.
But
which toxins? That's a good question.
It's a great question. No one can ever answer. They're always like, I'm getting the toxins out. I'm like, oh, which ones? And I've even had this debate with people who sell detoxes because they'd be like, they're like, everyone has so many toxins. Like, which ones are you getting rid of specifically? And they never know. If you like, there are things that like you actually need to go to a doctor for, but you don't buy the solution to, like, if you have a liver issue. Correct. You go to your doctor. You don't buy something off of Instagram that makes you have diarrhea.
Correct. And our inherent detoxers are, you have 3. You have 2 kidneys and a liver. You only need 1 kidney. There's some people born with just 1 kidney. Those do your detox for you. If those that are not working, you need to be seeing a nephrologist or a hepatologist who's a liver specialist or a kidney specialist. So, the detox is another, of course, scam. And so it's unfortunate. And one thing that I think you and I have discussed before that I think is really important to emphasize to your listeners is because sometimes when, as physicians or, people that are in health science having these conversations, it can seem like we're a little demeaning because we're saying, well, duh, it's just a scam. I want to remind everyone that's listening too that the consumer of the misinformation is the victim here because everyone is just looking for health solutions for problems. I have literally been absolutely confused. If it's not within my specialty, I can tell you how many dermatology, skincare scams I could easily fall for. And then I'll message my friend who's a dermatologist and they're like, that's a scam. It's so easy to be confused because if it's not in your area of expertise or if you're not in healthcare at all, it can be so confusing. And then there's also authority bias. People with an MD that are affiliated with a big institution are selling you this scam, Mark Hyman, and it's like, it's that authority bias. They have an MD after their name, and that does not mean they're not predatory. They're still promoting misinformation. I know you had mentioned on your list adrenal fatigue. Mark Hyman is one of the biggest pushers of adrenal fatigue. The Endocrine Society had to come out with a statement that says adrenal fatigue is not real. And here's the thing. Your symptoms are real.
Yes.
So if you are feeling fatigue and you are feeling tired and you are not sleeping well, you are feeling all these things, those symptoms are real. And there could be an underlying etiology to that we may have a fix for. But someone preying on you with misinformation and selling you a cleanse for it or a pill for it or adrenal support pill is really, to me, the lowest form of low, especially when they're a physician and they should know better or a scientist. And so, just to make it clear to your listeners that, we joke about how this is so ridiculous, but I totally get where you're coming from and how you landed there because it is, it's a function of people just looking for health.
I like that you clarified that the symptoms are real because whenever I discuss this, people often think I'm saying that you're not fatigued, you're not tired, you're not having it. No, I'm like, I believe you feel all of these negative symptoms going on. But that doesn't make it adrenal fatigue. There could be other underlying issues that need to be addressed, absolutely. But the term adrenal fatigue is not even recognized in the scientific community.
Literally. Endocrine Society literally has a statement, which I implore anyone to read, where they go through the data about how it's not real. And the other issue is that, yes, so sometimes these constitution of vague symptoms can be something else, and it can be something diagnosable. And guess what? This is where uncertainty comes in. Sometimes someone has symptoms that you do a sleep study. They don't have sleep apnea. You check their blood work. Everything looks okay. They still have those symptoms. Those symptoms are still real. This is where I think, physicians need to do better about expressing uncertainty and saying, your symptoms are real, and we will continue this journey to figure out what this is and support you in any way we can, even though we don't know exactly what it is right now. That doesn't mean that the alternative, let me give a name to what you're feeling and make it up and sell you a treatment for it, is the right answer. We just do have to, rather than being dismissive, we have to, explain to patients that there are areas of uncertainty of medicine and that we will use the best available science that we have to help patients move forward. But we may not always have an answer, but that doesn't mean that this case is closed.
Mm-hmm. You're going to love this one. You said, and I quote, LDL cholesterol unequivocally causes atherosclerotic cardiovascular disease. I want you to explain this so simply a 5-year-old can understand it.
Absolutely. So one thing is that, for your listeners who are not because it just depends on your algorithm. Some listeners may be like, I've never heard of this. And some of your listeners may be like, actually, I've heard many times that it doesn't cause cardiovascular disease.
Someone on Instagram said that's not true at all.
So LDL cholesterol, so when we talk about coronary artery disease.
And I'm going to interrupt you just one second because I just want to clarify. If there's a single person you should listen to on this topic, on LDL, on cholesterol, on heart health, please, for the love of God, listen to this woman right here. This isn't another random person on Instagram. This is one of the most highly qualified individuals in this field. Please listen.
So nice of you.
Keep going. I apologize.
Well, thank you so much. That's so nice of you. Well, so LDL cholesterol. So when we talk about coronary artery disease and when we talk about atherosclerosis in general, even paring it back a little bit, what is atherosclerosis? So when you look at the vessel wall, whether it's the vessel wall in the arteries in the heart, so the coronary arteries, or the arteries that go to the legs, or the arteries that go to the brain, or the arteries that go to your genitals, all of these arteries have a similar structure, and the only substrate required to cause coronary artery disease is an elevated, what we call this atherogenic lipoprotein. That means the lipoproteins that get into the vessel wall and cause plaque buildup. And that is LDL cholesterol and what's called ApoB. And without diving too deep into it so your listeners don't tune out or fall asleep, essentially every LDL particle has a certain amount of LDL cholesterol in it, and every LDL particle has an ApoB. So the reason why I mention ApoB is because some of your followers may hear one or the other.
It's a huge term and it's important.
It's important. But so they essentially, for all intents and purposes, they're used interchangeably. There is some nuance between ApoB and LDL cholesterol, but every LDL particle has an ApoB. Now, that is the only thing required to cause coronary artery disease is for those atherogenic lipoproteins to get in the vessel wall. And so why do people say, well, if I don't have high blood pressure or diabetes, doesn't matter what my LDL is? And that's false, because the only thing that's required to develop atherosclerosis is elevated, cholesterol of these lipoproteins. That being said, things like diabetes and high blood pressure and smoking raise the risk of developing cardiovascular disease because the endothelial lining, the lining of the vessel, is weakened, and at a lower threshold, cholesterol particles can get into the vessel wall. But the reason why the same underlying etiology for coronary artery disease is the same underlying etiology for the vast majority of, for example, vascular erectile dysfunction and peripheral artery disease, because the same way cholesterol builds up in the vessels that go to the brain is the same way cholesterol builds up in the vessels to the genitals and the vessels to the legs. And so the magic of this in that cardiovascular disease prevention, by preventing coronary artery disease, we can try to prevent plaque buildup with cholesterol buildup in the vessels in the whole body. And so with regards to LDL cholesterol causing cardiovascular disease, it's really interesting because I feel like I live in two worlds. I live in the academic cardiology world where, we go to the American College of Cardiology conference, the American Society of Preventive Cardiology conference, the AHA conference, and, European Society of Cardiology conference. And at our big academic meetings with cardiologists from all over the world, there's absolutely no debate whether or not LDL cholesterol and ApoB causes coronary disease. There's literally no debate. There's actually no floor to how low we want someone's LDL, right? The debate only exists on the internet and in these spaces, but in actual scientific world, and this isn't just the US, this is the Canadian Society of Cardiology, European Society of Cardiology, South America. This is worldwide. There's consensus and expertise. And this is based on not just one study, two studies. This is based on decades and decades of research, ranging from Mendelian randomization studies, genetic studies, actual exposure studies, lipid lowering studies, and so that's unequivocal. And so it's interesting though, because the misinformation is powerful, and even though this is not debated at all in scientific area. And even saying, with me hedging to say, I did mention scientific uncertainty. We don't have uncertainty about this, actually. This is very much something that has been demonstrated and replicated over decades and decades of time. And so, it is one of those things that the misinformation, though, does kind of have legs of its own. And sometimes when you log onto the internet or onto Instagram or X or TikTok, you may think like, oh my God, where have I been that suddenly there's like a new wave of this rumor? And it's good. I tell doctors all the time that it's good to have a pulse on what's going on social media, because that's where our patients are getting a lot of their information.
I wasn't going to bring this up now, but you actually briefly mentioned it. You said erectile dysfunction can be an early sign of heart disease. Can you talk about that?
Yes. So we actually published a research paper on different lifestyle interventions and things for cardiovascular disease prevention that can reduce risk or even improve erectile dysfunction. And that's because some amount of erectile dysfunction is psychogenic, but then some amount is vasculogenic. And so we call it a canary in a coal mine, because the research shows that erectile dysfunction can present, as much as 5 years before someone's first cardiac event. So when someone has a sign of erectile dysfunction, think about the vessels that go through the body, the arteries, then the entire vasculature. The same way cholesterol builds up in those vessels is the same way it builds up in the coronary arteries. How does Viagra, which is called sildenafil, work? It's dilating the arteries, right, to increase blood flow. But what if we were one to prevent that plaque buildup in the first place in both the coronary arteries and the arteries to the genitals, as well as the arteries to the legs and to the brain? And also, what if you were able to implement lifestyle things, eating a Mediterranean diet, a healthy DASH diet or a plant-based diet, exercising, smoking cessation, all of those things that we know reduce your risk for cardiovascular disease, as well as treating those risk factors as well, things like diabetes and hypertension and weight management. And so, it goes really hand in hand, and it's a really important risk factor because it's sometimes a window into what is going on with someone's coronary artery disease. And we say in cardiology, truly prevention is the best intervention. So the earlier we can get someone on the right track with their risk factors, the more we can improve their outcome.
So let's say you have someone sitting in front of you. You have a patient. You said there's no floor to how low you'd like LDL to go, and you have a patient who's trying and trying and trying to improve their cholesterol. And I would like to talk about the other types of cholesterol as well. But what are your go-to recommendations for someone whose LDL is too high, ApoB is too high? Before we talk about medical intervention, let's purely just discuss lifestyle first. What are the number one things people need to do?
So, it depends on also, there's a little nuance there because it depends on what their baseline number is. So we have a do not stop, pass, go, do not collect $200 number, which is an LDL of 190, because that makes us concerned for something called familial hypercholesterolemia. And just to keep in mind that regardless, in cardiology, in all of our guidelines, you'll see for hypertension, for hyperlipidemia, for coronary artery disease, for heart failure, you will see the class 1 recommendation, regardless whether or not you need medications, is always lifestyle intervention, which is always going to be eating a plant-predominant diet. It does not have to be plant-based. It can be plant-based, but a very plant-predominant diet can be a Mediterranean diet, a DASH diet. This can look a multitude of different ways, but that's high in fiber, eating lots of fruits, vegetables, legumes, whole grains. If you eat fish, fatty fish is really beneficial, low-fat dairy. A diet that is low in saturated fat. So, at least trying to get, if you can, your saturated fat to less than 7% of total calories. But this is not a low-fat diet, because we know that eating a diet that's high in poly and monounsaturated fat can lower your LDL cholesterol. These are the major dietary interventions that can help with lipids. Now, exercise doesn't make as much of an impact in lipids, but exercise makes a major impact in health. Exercise helps reduce cardiovascular risk, reduce your risk of heart attack and stroke, improve your longevity, improve your functionality as you age, reduce frailty. So it's a different lever to pull, and it's incredibly valuable, but it's not going to have the same impact on lipids as diet. Now, all of that being said, you could be on the absolute most amazing diet and still have high cholesterol, and that could be genetic. And so there's certain genetic etiologies of hyperlipidemia that we look into. There's a new test now over the last few years that everyone should have a one-time check of something called lipoprotein A. Have you seen that on social media?
Of course, I was going to talk to you about it.
Oh, okay, great. So that's another atherogenic lipoprotein, and it is elevated in 20% of the population, and it's genetically inherited. So you can't do anything to change your lipoprotein A.
There's nothing you can do to change it.
You can't, at this time, there's nothing you can do to change your lipoprotein A. There are a multitude of drugs. There's about 3 drugs that are currently being studied in phase 2 and phase 3 with readouts that should be in the next couple of years for lipoprotein A. We have to see what those hard outcomes show because at this time, we don't know. We know that the drugs can reduce lipoprotein A. We don't know, does that translate to reduction in heart attack and stroke, right? Because you have to have not just the biomarker reduction, you have to have the hard outcome to say that this is actually a valuable intervention. And those trials are underway and the readout should be in the next few years. But currently for people who do have a genetically elevated lipoprotein A, we look at a variety of things, how high their lipoprotein A is, do they have other risk factors, family history, and we try to, for them, depending on how high it is, we want to reduce the factors we can reduce as much as possible, their LDL cholesterol and ApoB, depending on where they fall on this spectrum. It's very individualized because of their own individual risk. We may use medical therapy, we may not. For people with familial hypercholesterolemia, which is a genetic kind of high cholesterol, it's it's one of the most common actually genetic forms of hyperlipidemia. And this is generally diagnostic when someone has a LDL greater than 190, not always, because sometimes that can be from a keto or a carnivore diet or, something else. But if they do have genetic familial hypercholesterolemia, although we do recommend those dietary interventions in the lifestyle regardless, those are individuals who are going to need medical therapy regardless. And so the most important thing is that knowing your numbers. Getting your numbers checked, knowing what your hemoglobin A1C is, your lipids, knowing your blood pressure, getting a home blood pressure cuff. And I'm sure you and I will get into this as well. Oh, right there it is. So important. And knowing your family history, if possible, for women, especially your pregnancy history is really important. Do you have a history of gestational diabetes or preeclampsia? These are really important. And that carries on to your post-pregnancy life as well. Really just knowing your numbers and then meeting with an expert. And it's never too early to say to your primary care doctor, I want to meet with a preventive cardiologist or a cardiologist, because primary care doctors are really the unsung heroes of medicine. They have so many balls in their court. And I always say, any subsect of cardiovascular disease, you can't expect your primary care doctor to know absolutely everything about everything. You can always just ask for a referral to a cardiologist.
Before we get into medication, statins,
Yes.
all that stuff, I want to ask, because I really want to focus on what people can take control of before we get to medications.
Fiber.
Would you say that saturated fat is saturated fat intake is independently one of the biggest, if not the biggest, issues in terms of overeating it leading to cholesterol issues?
Yeah, so this is also unequivocal. So this has been demonstrated in a tremendous amount of research over time. So saturated fat is linearly, like a direct linear relationship with saturated fat and LDL cholesterol and ApoB. Linear. And that means the more saturated fat you eat, the more it will raise your LDL cholesterol and your ApoB. And the less saturated fat you eat, the more it will lower it, regardless. And this has been demonstrated in so many randomized controlled trials. It is unbelievable. And we're talking about the most tightly controlled randomized controlled trials you can imagine, free living studies, as well as metabolic wards. For anyone who's skeptical out there that really wants to know, look up Ronald Mensick and his, it's a zillion page paper that was done with the World Health Organization that goes through a gazillion trials where they looked at the direct relationship of saturated fat and LDL cholesterol. So it's directly related. That being said, we don't expect patients. There's no such thing as a perfect diet. And so it's all in terms of, the totality of your full dietary pattern, right? So it doesn't mean you can never eat anything with saturated fat in ever. It's impossible to be on a saturated fat-free diet because avocado, has mono and polyunsaturated fat, but it's going to have some degree of saturated fat. Some degree of saturated fat will end up in your diet. But the threshold we see in a lot of our recommendations, about 6 to 7% of saturated fat, if you can keep your diet underneath that, generally, we see the most benefits. It's a gradient though. If hitting 10% is the best, you can do at this time, that's okay as well. We also emphasize it doesn't have to be all or nothing. We want people to increase their fiber, reduce their saturated fat, but sometimes, you can't do it all at once. And so it's a goal to strive for.
I think about it like steps. We know definitively that starting like for every extra 1,000 steps that you take a day, up to about 7,500, you see massive drops in all-cause mortality.
Yeah.
We see like from like 2,000 steps up to like 7,500 steps, we see like a 42% reduction in all-cause mortality.
Right.
Which so like for every extra 1,000 up until there, you see massive benefits. So I think about saturated fat from the perspective of if you're having 25% of your calories come from saturated fat and you drop that to 22, to 20, to 18. For every drop, I would imagine the results would be tremendous.
Right.
Am I correct in thinking that? Am I wrong?
Absolutely. There's always going to be a gradient of like it's going to be, a greater reduction is going to be better than less, and so I agree. It does not have to be perfect. Stepwise is huge. It's incredibly important to just reduce, all of these variables in a way that also is sustainable for you. The 2025 American Heart Association, American College of Cardiology hypertension guidelines came out a few weeks ago. They are over 100 pages. I highly recommend anyone read them end to end like I did. They're phenomenal. Our last hypertension guidelines in cardiology were in 2017, so this was long awaited. And they actually became, our sodium guidelines are actually highly recommended now that we keep sodium to less than 1,500 milligrams a day based on, the totality of evidence and tremendous evidence on sodium reduction and cardiovascular disease, alcohol reduction, aiming for abstinence if possible, knowing that we also have to be realistic and meet patients where they're at. So if abstinence doesn't work for them, maybe just reducing by 25 or 50%, any amount that they, meeting people where they're at. And just like the step analogy is a great one because for some people, getting to that first threshold of adding another 1,000 steps is going to be huge. But sometimes you may notice this with people you work with too, that sometimes momentum builds.
Yes.
As people start to see changes and as they feel better and their blood work gets better. Sometimes it's just getting the ball rolling can really be beneficial. And also giving yourself some grace and not feeling like it's progress over perfection.
Yeah. That's one of the reasons why, there are many reasons why, but one of the reasons why I'm a huge proponent of getting blood work taken regularly, more than just the annual, which I know like there's a lot of disagreements on that.
And we may disagree on that.
But the reason I like it is because I see real-time behavior change. In the gym, when people see I went from this weight to this weight,
right?
If you only saw progress once a year in the gym, you'd be so much less likely to go. I understand there are potential issues with more regular blood work, but I know for a fact that if you're getting your blood work done quarterly or even twice a year, and you see, wow, my cholesterol went from this to this, it's working. They just need to see it in front of their face, that for me is enough to say, go get it more frequently then.
Yeah, I think it can be highly motivating. And, I agree. This is me being like a little bit of a stickler with evidence-based medicine. There's a lot of patients, any of my patients listening will be like, you check my blood work all the time. So I do check blood work frequently because of a variety of different reasons. We're doing a dietary trial, we're making a medication adjustment, et cetera. There is, of course, a caveat and there's this nuance with regards to over-testing and over-diagnosis and things like that. But yes, do I think that in many ways that it can be motivating? Someone makes a dietary change and then sees the results.
Yes.
Absolutely. And also like even just, when you start to make some dietary changes like the ones that, thankfully, one thing to remind everyone is that even though a lot of dietary stuff or things like this seem to be debated on social media, keep in mind that actually in the real world, that when you look at the Endocrine Society, the American Diabetes Association, the American College of Cardiology, the American Heart Association, the American Society for Preventive Cardiology, the American Gastroenterology Society, the American Rheumatology, College of Rheumatology, actually, and also all of the cancer societies, all of the dietary recommendations are the same. And you will see that there's synergy across all of the guidelines, which means you don't need 8 different diets for 8 different disease prevention methods. The same dietary pattern has shown to have tremendous, benefit and risk reduction for a lot of chronic disease. And so I think that there's something really valuable about that. Is that boring? Meaning, can I package something specifically to sell you? No, because it's available on the American College of Cardiology website for free. You can go on there and say, what do the guidelines say about diet? And so that's where it's like a little less sexy or marketable, but that's what the science shows. And I think that there's something that some people find relieving about that. They're like, oh my God, I don't need to follow 18 different diets to prevent 18 different things. It's the totality of your dietary pattern, but a lot of these are small, sustainable changes over time that can really lead to benefits in the long run.
The way that I view things is from a behavioral perspective. That's the lens that I look through because you talk about the guidelines, which very few people are going to go read that 100-page paper.
Of course.
So one area in which the fitness industry, coaching specifically, has lacked basically forever is in behavior. I will say, to the industry's credit, I'd say over the last 10 years, there's been a huge push towards understanding behavior change and getting clients like, listen, if you just give them the program, that's not coaching.
Right.
And so one area that I think that the medical sciences can improve on is it's not just about these guidelines. We have to understand behavior. And going back to blood work, I understand that there can be potential issues with more frequent, but like you said, even with your patients, you might get blood work more frequently. I push people to advocate for themselves and to get blood work more regularly, because if you're proving to yourself that it's working, that's how we get change. That's how we inspire confidence. We increase self-efficacy within them. It's like if I only got it once a year, I wouldn't have motivation. And a lot of times, like, how many people do you know realistically who follow the exact same diet for a year straight? Very few people.
Right.
Whereas if you're, hey, just for 3 months, follow it. Just for 3 months, we're going to redo labs after that.
Right.
I think that's enough for them to say, oh, wow. My cholesterol's improved. My ApoB's improved. Whatever it is, even if you don't have to necessarily get labs done every quarter or every 2 times a year for the rest of your life. But even if you spend a year or two tracking it as data, as we do in the gym, you track your weights lifted. Like, I think there's a lot to be said for that from a behavioral perspective.
And listen, I would not disagree with you. And with regards to, like, if I'm doing a dietary trial with the patient, we're trying to make a decision, are we going to do medication versus or how much medication we're going to need versus just see how aggressive we can go with the dietary trial. This is in primary prevention specifically. We may repeat in 8 to 12 weeks and see. That being said, I will say what you just mentioned, and I'm going to push back on you.
Please,
I love
please.
you dearly.
I love that about you. Push back.
What you mentioned, I think, is a great hypothesis, right? So for me to actually say checking blood work more often at this interval is very beneficial, we would have to do a randomized controlled trial, randomize people to getting their blood work more often. Does it actually change behavior or does it not? And I think that's a valuable question, something worth studying. But you can't say for sure, because on the other end of the spectrum, you may find that there may be some people that it gives them more health anxiety.
Yeah, for sure.
There was a great example, was the Apple Watch study, right? So I was the biggest hopeful person on earth for it, because I was like, oh my God, it's going to detect all this atrial fibrillation. We're going to prevent all these strokes. Well, after like thousands of people they looked at, they found that not only did it not detect an extraordinary amount of clinically significant arrhythmia, it sent a lot of people to the ER with anxiety. And so you have to also think of, this is why we need randomized controlled trials. This is why we need science.
Course.
Because, that's a great hypothesis. And I will say anecdotes are the lowest form of evidence, but I will say in my own clinical practice, when someone sees their lipids improve with the diet change, it is motivating, right?
100%.
But I've also had patients that doesn't matter whether or not, I'll tell you, even if their LDL cholesterol comes down 60 points, and they will say to me, I hated every minute of the diet in these last few weeks. And they think that they hit the finish line. And I say, no, those diet changes that you made to drop your LDL this much, they have to be sustainable. And if they aren't, that's okay too, because we do have medical therapy if needed. Or maybe it's just trying a different way, different. And so I would say that I agree with you that it can certainly be motivating, but the really stickler in me says we'd have to study it.
Well, the thing is, I don't disagree with that. Yeah. I think that both can coexist.
Yeah.
I think we can have this hypothesis, and from your own experience, that there will be people who benefit from it.
Yep.
And we should study it.
Study it. Yeah,
I
absolutely.
I don't think it's an either or.
Yeah.
And in terms of the people who like, they go through it, listen, we'll talk about your strength training, but even you said early on you hated it.
The only reason why I'm committed to strength training for everyone listening is because of Jordan's diet.
And we'll talk about that. I'm very excited
Yeah.
and I'm super proud of you.
Yeah.
What, again, my whole lens is behavior.
Yeah.
That's and I always try and figure out, because you can have the best diet in the world, you can have the best workout program, you can have everything planned,
Yeah.
but if they're not following it, it means fucking nothing.
Yeah.
And so everything for me is, how do I get people to stick with it? And for me, a huge portion, one of my favorite researchers is Alfred Bandura, when we're looking at the self-efficacy in terms of how people with a very high self-efficacy are more likely to succeed in whatever their goals are. And so my job, or my goal is, and part of my job, how do I get people to believe in their ability to succeed? Because when they believe at a higher level in their ability to succeed, they're more likely to stick with it. How do we prove to them that they're able to succeed? Show them.
Yeah.
Show them. And we have a lot of research on this. And he has so many different models on what leads people to believe in themselves. Social modeling. It's funny. Like, one of them is actually success stories from other people.
Yeah.
Like when you model someone, or why your spouse can be such a huge component of it.
Yeah.
But if you show someone the proof, it's more likely. And I'll give you an example out of the inner circle. One thing we recently added in the last 6 months or so is at the end of every workout, we calculate your total volume for the workout, which basically means like it shows you how much weight you lifted in total.
Yeah.
So weight times sets times reps, and
Awesome.
people are lifting thousands of pounds. And so when I tell you, we can look on the back end and we can see how many more people are checking in more consistently
So cool.
and doing the workouts, because they're like, it was one thing to finish the workout and get like a great job message.
Yeah.
It's another thing to finish the workout and say, hey, you lifted 6,822 pounds. And then the next week it's like, you beat that. And the next week you beat that and you beat that. So it's showing them time and again,
So cool.
which for me that's blood work,
So cool.
right?
Yeah.
You can, hey, this is where you were. Now this is where you are. Now this is where you are. Every 3, 4, 6 months, whatever. I just think a year is too long. And then even then, I don't think people are doing it annually.
Yeah, well, so it depends on the
Of course.
scenario. So there is a lot of research. I agree with you. I think there's some degree which it may be beneficial. There's some degree that, there's a big rabbit hole that we could go down on over testing and over diagnosis, which has its own harms. And there's a huge aspect of the evidence-based medicine community, especially out of Oxford, the Center for Evidence-Based Medicine, which really is one of the most incredible departments on EBM in the world. And they have really published some phenomenal research, because you would think, like, intuitively, you would think, well, testing for everything, like, why wouldn't I get a full body MRI, right? And see everything possible. There's actually significant, robust research that can show us that sometimes over-testing in certain areas can actually cause more harm. So, for example, if you do, the reason why we don't recommend full body scans for everyone just at baseline is because then what can happen is people go down, and not just what can happen, randomized controlled trials and different studies have actually shown that you can go down this diagnostic cascade, which can lead people to getting unnecessary biopsies, unnecessary further tests that actually end up causing iatrogenic harm. And so the problem with lab work, sometimes also in the hands of someone that may not know how to interpret it, it can cause, like, say if someone gets lab work and they were, taking like ibuprofen or something a few days before they had a cold, and their liver enzymes look elevated, and then they, of course, say if the person's like, oh my gosh, and then they end up seeing a hepatologist, and then they say, okay, we're going to do an ultrasound. And not that an ultrasound is harmful, but you go down this diagnostic cascade where, sometimes you can catch things early, but then sometimes you can end up getting over testing, biopsies that can have complications in them. They're not benign. And so I think blood work is the most benign of them, but I would venture to say, to fully say that, we should all be on a every however many week or month schedule of lab work is beneficial. We would need an RCT to show. Now, that being said, when I was saying I check blood work on patients, because I also think it's shared decision making. So when you're working with the patient and you know that, like, they're saying, I want to see how my lipids change in 3 months, and they know that's going to be motivating for them. Of course, I think it's a risk benefit ratio, right? There's no downside for me. So I think that it really, I would agree. I would venture to say, that more patients and more individuals in the general public would benefit from more, truthfully, getting care from, of seeing their doctor, getting things like evaluated, looking at family history and knowing those numbers. And there's a lot that people can do. Like a blood pressure cuff is something everyone can buy on
Yes,
Amazon.
please.
And everyone should have a blood pressure cuff because you had elevated blood pressure and you were exercising,
Yes.
you're not overweight. And I thought the work you did to promote how important blood pressure is, it's like some of those incredibly valuable work you've done because you are the picture of health, right? And people would say, well, Jordan Syatt, there's no way he can have high blood pressure. Look at him. He's working out all the time. He's fit and all this stuff. But it goes to show blood pressure is the silent killer and for a reason. And I just think you've spread so much awareness about the importance of it. And that's a tool that everyone can get, by the way, in the new guidelines. So you guys don't have to read it. There was another reiteration. I think this is really important. Is that, checking home blood pressure, incredibly valuable, but also the cuff. You want to make sure it's validated. Wrist devices are not validated.
Correct,
They actually call that out in the guidelines. Brachial, so upper arm cuff only. And so, yeah, I think you've done a great job, emphasizing that's a great way people can also evaluate their health. And, there's other metrics to that, but that's something people can do at home too.
So I want to talk about blood pressure now. You wouldn't believe the messages that I get from people who listen to the podcast, in terms of, I didn't think it was a big deal. I checked it. It was 180 over 110. They go to the crazy messages. So again, from my view of behavior, I try and do things very deliberately. Nothing I post is by mistake. It's very deliberate. And so the whole reason that I decided to get a blood pressure monitor is because someone posted on Instagram I saw two stories on Instagram within a very brief time frame about young, healthy men dying. And when I say healthy, otherwise healthy. They look fit. They worked out. They actually ate well. And one of them was literally on a boat with his children, had a heart attack and died. And I was like, you know what? I'm going to get one. It was $20 on Amazon. Let's try it. Right. And it was high. And keeping in mind, it was very surprising and very demoralizing. And scary.
Because health is your whole thing.
Everything. Yeah. And listen, I was eating well, exercising, but here's the thing. So every time I would go to the doctors, they would take my blood pressure. Every time they'd be like, it's just white coat. It's just white coat. It's just white coat. And I was like, cool. Must be, whatever. And I hadn't done much research into it. Right. Now I'm at home, calm, testing, wait 5 minutes, testing, wait 5 minutes, high, 140 over whatever. And I'm like, holy shit, this is a problem. And so now leading into, I just pulled a 106 over 67 the other day. Just I check once a week, whatever.
Beautiful. Amazing.
I'll get these messages from people who send me really scary stories. Yeah. And I will deliberately share them on social media because the only reason that I started is because of fear. And I've found that often, I'm sure you see it, a lot of people only take the step for their health once they get scared shitless. Yeah. And so and this is a whole separate conversation on behavior, using fear as a motivator, but I found fear is a tremendous motivator to get people to sometimes do what they need to do. Right. This is why we see, people hit rock bottom before they decide to make a change. Right. I think there's some level of fear that we can use in a healthy way to motivate people to, hey, let's get the fuck, let's check your blood pressure.
Yeah. And I think what you've done that's great is that you have been the picture of health for you to say I had high blood pressure and, you're not this prototypical what you would expect with high blood pressure makes people think, oh my gosh, if Jordan could have high blood pressure as possible. What I love that you just spoke about, which I think is so valuable, is blood pressure reading technique. And this is you have clearly educated yourself so much about this.
I've studied this so much, Danielle.
It's amazing. And so I know will enjoy the 2025 100-page AHA hypertension guidelines. One thing that's super emphasized in the hypertension guidelines is the importance of home blood pressure monitoring. And why is that? Actually, when you look at the amount of individuals with true white coat hypertension, it drives me nuts I feel so bad for patients because patients sometimes are kind of dinged around for years telling them the exact same thing. It's just white coat. That is actually not the evidence-based way for doctors to do it. They shouldn't just say it's white coat, you're absolved of this. It should say, okay, your blood pressure is elevated in the office. It's either stage 1 or stage 2 hypertension. You need to get a home blood pressure cuff and you need to start monitoring your blood pressure twice a day. Morning, first thing in the morning before you get up, before you brush your teeth. You want your arm resting at heart level, both feet on the ground before you take any medications, before any caffeine. and then do an evening reading before dinner, 1 hour separated from exercise and caffeine, and get a good idea of what your true home blood pressure is. Why is this valuable? It's valuable for two ways, because the vast majority of people who think they have white coat hypertension actually don't. They have sustained hypertension. Also, 5 to 10% of people with true white coat hypertension transition to having sustained hypertension in a year. And so either way,
That's interesting.
Yeah. So either way, it's really important to know what your blood pressure is and to know, how it actually looks. The other thing too is that if you do check your blood pressure at home, say if you go to the doctor and it's like you have knee pain or whatever, and it's like 140s or over something, it can actually prevent over-treatment. Because if you say to your doctor, I know I'm really stressed today, you were in traffic, you had a work meeting, et cetera, and their blood pressure is high. But you say, listen, I check my blood pressure, 3 days a week, morning, night, et cetera. It's always 120 over 60, 120 over 70, less than 120 over 80. And that is just an isolated insulin. It prevents someone from just, also slapping medications on you that you may not need. And so it really is a valuable tool. But high blood pressure often doesn't have symptoms. That's why it's called the silent killer, and it increases your risk for, of course, heart attack, stroke, cardiovascular disease, dementia. Similar as high cholesterol, increased risk for dementia as well. So, it kind of all goes together. And I think that the amount of awareness you brought to high blood pressure, because it's a very unsexy, kind of boring topic. I mean, I find it fascinating.
I do.
But you made it more, of a, I think you've done a great public health service by raising awareness about it.
Again, always back to behavior. Whenever I post about blood pressure or cholesterol on my stories or something, I just see views plummet. People are just not interested, which is why all right, what can I do to really get them interested in this story? That's a huge part of how can I get them interested in the story of blood pressure? How can I get them interested in the story of cholesterol?
Right.
It's I'm always, and I think, so for example, doctors, you say you should tell them, get a home blood pressure cuff. My brain goes to, how many times for example, I go to the dentist and they'll be like, you should get XYZ a water pick or flosser. I'm like, if you gave me a card with a QR code to scan with this exact one that led me directly to it on Amazon or a store, I'd be so much more likely.
Right.
Every doctor's office should have a picture at the front that says, this is the home blood pressure monitor cuff that we recommend. Just get it right here.
So true.
I'm just thinking what is the easiest way to get people the least amount of barriers?
Right. Least amount of barriers. You're so right. Question for you. When you post, because I am so thankful that you are so pro-science and you emphasize to the fitness community that LDL cholesterol does cause heart disease and things like that. Do you ever get pushback?
Are you kidding me?
I know. Do you?
I get pushback on everything.
Oh,
I could say, I hope you have a great day, and I get pushback. Of course, I get pushback on everything. I told you before we started recording, I talk about raw milk. I had no idea how many adults drink and love raw milk. I had no clue. And I'm saying, listen, if you want to drink it, go for it. That's fine. But people get really upset, whether it's raw milk or seed oils or LDL. People, I get it. People get furious.
Wow.
Furious, yeah.
Wow.
Okay. Which is, it's also funny because you were talking about how when you're at these events with all these cardiologists, there's no debate about it. Same thing with seed oils. All the seed oil researchers are shocked that there's all of this debate around it. It's no, it's when you look at the research, it's pretty clear there are no issues.
In our nutrition clinical practice statement for the American Society of Preventive Cardiology, we literally, canola oil, seed oils, they are high in polyunsaturated fat. They lower your LDL cholesterol. They are not the demon, Also, I'm not telling people to drink it either. But the thing is the myths really take on a life of their own. And so, one of the things that you and I have talked about too is how when those myths, as a cardiologist, the sad thing is that, my focus is cardiovascular disease prevention, but the hardest thing is that at the end of the day, people can go back and forth about debating this pseudoscience on social media. But at the end of the day, sometimes as a cardiologist, we are the last stop. Mm-hmm. And that is heartbreaking because there's people that I see that I wish more than anything they accessed good evidence-based information like what you post about cholesterol and hypertension and all of these important variables rather than just the luck of the draw, getting the wrong algorithm, the wrong pathway, and then seeing me with significant end organ dysfunction, severe triple vessel coronary artery disease, having a terrible prognosis, which is all preventable. And, the misinformation, it does kill. And so it's sad though, because, at the same time, there's only so much you can do and so much you can reach. But, what you do is valuable because you are reaching, I think, a subset of people that otherwise may not be, believing this about cardiovascular disease risk.
And for whatever it's worth, like, I know you're not posting as frequently. You're doing so many other things.
Busy.
I'm quite jealous. But I will say, when you post, it helps me because then I can try and take that information and tell a story about it in a way that hopefully is more digestible to the everyday person. So your posting helps me as well and helps everybody through my channel. So thank you for that.
Thank you.
Okay, now this one I thought was really interesting. I saw your post. You said HDL cholesterol being labeled the good cholesterol is a myth.
Right.
Can you talk about that?
So HDL cholesterol, I'm so glad you asked this. And I feel like this is really deep in the weeds. So I hope your listeners aren't going to
A lot of the listeners really like this stuff and they appreciate it. So please,
I'm sorry if this is boring. Don't miss the rest of it. Just maybe get
There's a lot
snack.
more coming, GLP-1 stuff coming, a lot more stuff coming,
But HDL, so, it's a big myth. Actually, I feel like even when I was in college or early on in medical school, they may have said oh, HDL, the good cholesterol, LDL is the lousy cholesterol. And now, with all things that are science is, an evolving, area of just different levels of evidence and research that helps to establish and understand things. Okay, so HDL cholesterol. So HDL used to be thought of as possibly the good cholesterol, and then what the lipid research has shown extensively over the last 2 decades is that we actually do not quite understand HDL cholesterol. This is an area of uncertainty. HDL remains to be an enigma. And why is that? We don't have a great assay to find its functionality. So what does that mean? Well, it means that when we've done randomized controlled trials, and there have been several randomized controlled trials to raise HDL, they've all failed. They've all failed. Any trial to raise that quote unquote good cholesterol have all failed epically with different drugs, with different supplements, with different things to raise HDL cholesterol has failed because it does not reduce your cardiovascular disease risk. Then what else do we find?
Wait, when you mean it failed, are you
Failed
saying
to show any benefit.
Oh, got it. So you were able to raise it.
Oh, correct.
But it failed in terms of
meaning
that.
failed with regards to outcomes. So meaning they failed to show a reduction in cardiovascular
Understood.
disease. So whether it's niacin, whether it's a drug that raises HDL, it doesn't. There's been multiple randomized control trials using different interventions to raise HDL, and these trials have failed to show a reduction in cardiovascular disease, in heart attack, in stroke, in coronary artery disease. And so then, you also look at different levels of evidence and you look at, okay, well, what about people with super high HDL? We actually find that can sometimes be harmful. We actually find that sometimes there's people with super high HDL and that may actually cause more atherosclerosis. So HDL remains to be an enigma. We don't have the answer to it. So what does that mean for us in cardiovascular disease prevention? We know what causes coronary artery disease, and this is those atherogenic lipoproteins, ApoB, LDL cholesterol, lipoprotein A. And so those are the things we target. Whether your HDL is high or low, it doesn't mean that it tells us nothing. When you look on a population level, and this is different than individual. When you look on a population level, if you see someone has lower HDL, if individuals in a population have lower HDL, higher triglycerides, things like that, yes, there may be some metabolic risk. On an individual level, it makes no difference. I have patients who go on an incredibly high fiber, low saturated fat, plant-based diet, and their LDL cholesterol drops to the floor. And their HDL cholesterol drops too, and that's normal, right? So there's absolutely zero evidence at all over the last several decades that shows us that raising HDL cholesterol has any benefit. Currently, it is an enigma. We know what causes coronary artery disease, which is these elevated atherogenic lipoproteins. They are our target. LDL cholesterol, ApoB, eventually lipoprotein A, once we have therapeutics for that. But whether or not your HDL is high or low, you do not need to target it. It is just something that is just truthfully an enigma at this point, an epiphenomenon that we know with some regards to, research with population data. Now, that being said, anyone that mentions to you any ratios, if they say to you, it doesn't matter that your LDL cholesterol is high because your triglyceride HDL ratio is fine, that is also made up. That should be like a red flag for pseudoscience. If they are using a ratio that has HDL in it, one of these triglycerides HDL ratios is actually completely clinically insignificant. So, and those are really common, like top hits of misinformation about lipids.
So let's say someone, they want to get their blood work done and maybe they want to be able to review it with a little bit of an an educated perspective.
Yeah.
Can you tell them what they should be looking at from a cholesterol perspective? Like, should they be looking at LDL, ApoB, lipoprotein little a, and what numbers generally?
And you know what? I would say it's so tricky. And the reason why it's so tricky and why I always recommend, I wouldn't even actually expect this perfect answer from even a primary care doctor, because as I mentioned, I did 3 years of internal medicine residency before I did 3 years of cardiology fellowship, but I don't remember a lot of primary care that I learned in medicine residency. So I don't expect primary care doctors to be as deep in the weeds as I am with lipidology. And so that being said, with regards to LDL targets, we have some targets, but that may shift depending on the individual. So I would always say, I would preface this and caveat it with, it's never too early to see a cardiologist who focuses on prevention. Never too early. We want prevention as early as possible. That being said, in primary prevention, so in someone without coronary artery disease, keeping in mind that there is no too low of an LDL, there's no floor, we ideally want your LDL cholesterol to be below 100. And, ideally as close to 70 as possible, below 100. Keep in mind that there's going to be new cholesterol guidelines that are going to be coming out in 2025, 2026. And so some of these targets may change and be more aggressive.
Even more aggressive. Wow. Closer towards 70, you think? Or 40?
We'll see. We'll see when the new guidelines come out. But no, not 40 for primary prevention likely. But, right now we ideally less than 100. It may and more towards 70, but it may end up being more. They're not out yet. I'm not privy to what theirs are going to be. I can't wait. I cannot wait for them to come out.
You get excited for those like I used to get excited for Harry Potter books.
Like it's literally like the day the new guidelines debut is like so excited. But with regards to, it depends on if you're primary or secondary prevention. So primary prevention is someone with no coronary artery disease. And so, and we can talk about how you detect whether or not someone has known coronary artery disease using different imaging and things like that. But in secondary prevention, someone who has established coronary artery disease, depending on how high risk they are, the European Society of Cardiology for really high risk individuals recommends going as low, like targeting lower than 40. The American Heart Association, American College of Cardiology recommends, less than 55. There's really no floor though. There's consensus in the agreement that the lower we can get people, the better. There's no harm to it going lower. But I will say that individual level that someone needs to target may depend on a variety of things. Whether they're primary or secondary prevention, their family history, their other risk factors as well. Do they have diabetes? Do they have hypertension? Are they a smoker, a former smoker? Do they have risk enhancers? This is like inflammatory diseases like lupus. Do they have a history of preeclampsia? Gestational diabetes. So there's a lot of factors in there. And so that's why I always mention, it really is, as much as guidelines help us to standardize care, but it has to apply to this patient sitting in front of you, which is why it's valuable to have that discussion with, someone who focuses on prevention. Keeping in mind, I also don't want people to feel panicked, like someone who has no coronary artery disease saying, oh my God, my LDL is 106. Am I going to, die? Of course, we don't want everyone freaking out either because, there's nuance there, right? So I think that there's, value in having that nuanced conversation.
Let's say you're sitting in front of that person with 106. Are you telling them, hey, we need to get it below 100? Like, what are you telling this person?
So, it depends. So if we're going to say, what's your LDL?
98 for the first time. Remember I told you? For the first time in my adult life, it's finally below 100.
Amazing. Okay, so 106. So, first of all, lipids are only telling you, one measure of time, right? So like, essentially, like it could be 106 one day, 3 weeks later, it could be 98, right. 3 weeks later, it could be 104. So that's like within the margin of error. I wouldn't, panic if someone's primary prevention about their LDL being 106. But it depends on a variety of variables. If their LPA is very, very high, if they have a family history of very early onset coronary artery disease, it may not mean by any means that we're going to start them on a medication. It depends on other variables and there are other risk factors. For example, if you have diabetes, if you have type 2 diabetes, regardless, it doesn't matter what your LDL is. The recommendation is, of course, diet and lifestyle is a given. But if you have type 2 diabetes, no matter what your LDL is, the guideline recommendation is to be on a statin. Do not stop past go. Do not collect $200. You're going on a statin because we know it reduces cardiovascular risk for people with type 2 diabetes. And so, so it depends on like a variety of other risk factors. But if someone has absolutely no other risk factors and no concerning significant family history, an LDL of 106, I would say, listen, I would just focus on doing the same lifestyle and dietary changes we recommend anyway and keeping an eye on their numbers and things like that going on, but forward. So it's kind of, the one thing that people can do that's really valuable that everyone can do from home is you can go into what's called the Prevent calculator. And this is our new calculator that helps to evaluate cardiovascular risk based on tons and tons of research.
This is cool. I didn't know this
done
existed.
by the American Heart Association. So you can go on, anyone can Google it, click Prevent. You put in things like your age, your sex, you put in your blood pressure, you put in your lipids, and it will give you a percentile of risk, 10-year risk of heart attack or 10-year risk.
That's really cool.
Yep, and everyone can do it. And I think that's
You just Google Prevent calculator?
Prevent calculator, yes. And I think it's something valuable that people can do to bring as a conversation starter with their physician as well.
Yeah. I love that. That's a great tool.
Yeah, it's great.
I'm going to do that right after we're done.
Yeah.
That's awesome.
And now I will say that even with Prevent, there's a little, so this is where we get in the weeds with academic discussion because there's a little bit of academic discussion that maybe Prevent, it may miss some people that our previous ASCVD cohort used to be like a little stricter with regards to it brought more people into the medical therapy realm, whereas Prevent may be a little bit more. It's our current calculator that we use, Prevent. It may be a little bit more less aggressive with regards to risk reduction and prevention. And this is something that is a nuanced topic that we do debate in cardiovascular conferences. We'll have people, we have debates all the time about primary prevention, the utility of being aggressive with medications in primary prevention versus not. But I will say that across the board, so even though we have debates about 70, 100, 40, 55, I will say that there is no gray zone with regards to, we know LDL cholesterol and ApoB causes cardiovascular disease. It's just how aggressive do we need to be with regards to beyond lifestyle for certain people.
You said 61% of U.S. adults are projected to have some form of cardiovascular disease by 2050. Heart disease is the number one killer of women and men, causing 1 in 3 deaths each year, claiming more lives than all forms of cancer combined. Yeah. And 64% of women who suddenly die from coronary artery disease have 0 previous symptoms. What do people need to know, if we haven't already discussed it, what do people need to know in order to prevent cardiovascular disease?
Yeah, so it's a great question. So I think that the first thing is that, we talk about primary prevention, meaning we want to prevent people from developing coronary artery disease, but we're getting so far as talking about primordial prevention, meaning even for your kids. There was a great study called the P-Day study, and this is like kind of a little jarring, but they had this study where they looked at, it was an autopsy study. So they looked at children, unfortunately, and up until their 30s, so from pediatrics to their 30s, who had died of other causes, things like drowning or car crashes or things like that. Very sad. But they had looked at their autopsies and they looked at their arteries, their coronary arteries and things like that, and they found that plaque starts to develop in 3-year-olds, in 2-year-olds,
Holy
in super young, 6-year-olds. We start to develop atherosclerosis and plaque in as young as you can imagine, and it starts to develop with time. Now, will everyone develop plaque when they were young? No, but what they did find that even in the children in these studies who did have atherosclerosis at a young age, at 19, at 20, because these are individuals who did not die of atherosclerosis. They died of other unrelated trauma, right? From like a car accident, like as I mentioned. Now, they found that the exact same risk factors existed. LDL cholesterol, diabetes, hypertension. So it wasn't at all discordant from what we see in adults. We know that coronary artery disease, generally doesn't develop overnight. It's a process that happens over time. And the magic of that is that we have so many tools to be able to prevent it. Of course, we have the diet and lifestyle things, exercise, eating the healthy diet that we've kind of discussed, at length. But also in the scenario where someone has a genetic predisposition, or maybe they just cannot get their lifestyle to be exactly where they want it to be at that moment. We have guideline-directed medical therapy that can help. We have, a variety of different interventions to diagnose cardiovascular disease early. So how can people prevent it? I would say knowing your family history, if you can, is important. And then, as we mentioned before, knowing your numbers, knowing your blood pressure, getting your blood work checked, your lipids, your hemoglobin A1C, a comprehensive metabolic panel, having a discussion with your doctor about your individual risk, checking your lipoprotein A one time, and, just being able to start to engage in that conversation. It's never too young. Truthfully, oftentimes when you end up seeing me, not always, because a lot of people, find me on social media and will see me earlier, which is great because a lot of cardiovascular disease you can prevent. But sometimes when people, by the time they see me, it's never too late, because even in secondary prevention, even in someone with coronary artery disease, we can still aggressively reduce their risk through guideline-directed medical therapy. But obviously the goal is, cardiovascular disease, truth be told, need not exist. Coronary artery disease need not exist. If we have all these risk factors in check, we know from a statistical standpoint, you can't develop plaque if you don't have a ton of circulating atherogenic lipoproteins, right? Or, and so a lot of it's controllable. That's actually one of the reasons why I went into cardiology, because in so many other fields, it's tough because you could do all the treatments in the world for certain kinds of cancers, or all the treatments in the world for certain kinds of autoimmune disease. And unfortunately, a patient could just still not get better. And the reason why I went into cardiology, specifically prevention, is because we are so spoiled in that is not the case. It is so preventable. And it's crazy because it is still the number one cause of death.
That's insane.
It's the number 1 through 5 cause of death. You know what I mean? And everything else kind of falls to the wayside. So I think it's because it's seen as something that happens later in life. And the truth is it starts to develop younger. It's just that the vast majority of people, the first time they find out they have coronary artery disease is at their first heart attack and stroke.
We've spoken a lot about knowing your numbers,
Yeah.
LP(a) one time, ApoB, all this stuff, HbA1c.
Yes.
I've had experiences with PCPs who refuse to order LP(a). They refuse to order lipoprotein A.
That's unfortunate.
And I get a lot of messages from people who say, like, I'm fighting
So
with
have
my
I.
doctor. How can people, I wrote down the question so I could say, how are patients supposed to advocate for themselves
Right.
and get these tests if their doctors refuse?
I know.
And what the fuck is going on? Why are they
I
refusing?
know. I've had people say say the same to me on social media. The standard recommendation now is like a one-time check of lipoprotein A. But I think that it's an issue with regards to, just like all professions, there's going to be
Of course.
great doctors, and there are going to be ones that don't follow the research, that have no idea. There's doctors out there seeing patients for telling people to go on a carnivore diet,
Yeah.
And so
It's crazy.
It's crazy. And that's the unfortunate thing. How do you advocate? I tell everyone this, till I'm blue in the face. The best thing you can do is sometimes, finding a physician that works for you. And it's not the most convenient thing in the world, but sometimes it's just trial and error. I tell people, if you do not feel like your doctor hears you out, gives you the time, and this may not be in the traditional healthcare model. It may not be all at one visit, right? You may need multiple visits to get all of your questions answered. But if they are someone that is not, willing to work with you, because evidence-based medicine, of course, is based on, of course, guidelines and scientific evidence. The patient's sitting in front of you. But the most important part is called shared decision-making. This is having a conversation. It's not a unilateral one-way discussion. Every single discussion is, at the end of the day, it's not just me telling someone what to do. It's discussing benefits, risks, their goals, their priorities, their cultural values, their interests, their fears, and their preferences. And so if you do not have someone that, you feel like is listening to you, especially about a test that's, recommended across the board to have one time screened, that's time to find a new primary care doctor. And sometimes, unfortunately, maybe you'll have to go 2 or 3, and that's not super convenient, right? Because then you're like, well, I have to take off work and do all this stuff.
It sucks.
But it's at the end of the day, and I know it's not convenient, it's not a perfect world and it's not a perfect system, but at the end of the day, it is your health. And I think partnering with a doctor that you feel like you're on the same team and you're working together and you can trust is the most important thing for your health.
We in fitness, and again, going back to behavior, in fitness, we talk a lot about environment.
Yeah.
And we look at access to food and access to things. And, you went to Drexel. So you know, for example, in Philly, the food deserts that exist. One of my best friends, Eli, he went to UPenn and he wrote his whole thesis on the food deserts. And I went with him. I walked around. I went from UD up to there and we walked around and we counted how many grocery stores were in a certain radius. Yeah. And then we went in and we saw how many of those grocery stores had vegetables and fruits. When I tell you that there was like a several mile radius where there was the only store that had any vegetables, it was in several miles, and the only vegetables they had was I'm not joking, a box of onions. Right. That's all they had. Oh. So when when you're talking about this, I'm thinking, okay, I understand how people struggle because when you say, well, find a new doctor, it's so easy, like it just comes off the tongue. We have to find a doctor. But then when it comes to practically, it's like, how many are close enough to you where you can go and you can sit down and have these conversations, get to know them, go through the insurance process, only to find out this one doesn't want to fucking order it either. Right. It's a real struggle for people.
Beyond a struggle, it's I wish in a perfect world, I wish every doctor was like, would follow the latest guidelines, would do shared decision making, would do all these things. And I think that, a lot of doctors do. And, sometimes I think, to their defense, sometimes they may just not know. So sometimes even I've had people say to me on social media, I just brought one of your Instagram posts and the doctor was like, oh, whoops. Yeah, I guess we should order that.
That's crazy.
I know. And in their defense, sometimes, they're with all the best intentions, they're just, maybe not up to date or things like that. It's beyond frustrating. I have no excuse for it. Our healthcare system is not perfect. There's an incredible amount of issues with it. And I don't have the perfect answer either because I can't look at a single country worldwide, despite there's many benefits to other countries' models and many negatives to other countries' models. Yeah. And so I do not have the answer. This is something that I do not pretend to be an expert in any way, shape, or form. And it's beyond frustrating. And one thing that you mentioned, especially even, in Philly, I was at Drexel and then, up at Temple for my residency. And then I was, in fellowship and took care of West Philly, North Philly, Center City. And, one thing that you mentioned, not, food deserts for sure. And then also, even those individuals saying to them, well, you should exercise more. And it's not even safe for them to leave their house.
Yes, exactly.
Right. So, this is where there's, a huge variety of barriers to everything. Yes. And, it's just, we have so much work to do.
Yeah. I always say, because privilege is a huge topic of conversation.
Of course, yeah.
I always say, I think the ultimate privilege is having 2 loving parents. Yeah. And then from there, having a great doctor who cares about you. Those are like 2 of the most amazing privileges you could ever have in the world. You've got great parents and a great doctor. Like, you are so well off. It's unbelievable.
It's really true. And I think that it's just in a perfect world, I shouldn't be having to say to the public, shop around for a doctor that follows guidelines. Correct. Like, that's crazy.
Yeah.
And unfortunately, I feel like the only way I am able to advise people is saying, you do have to be an advocate for yourself. Yeah. I also don't want people to just say, I'm just going to accept what this doctor says if it doesn't follow along with guidelines. I want people to get the best care they can and advocate for themselves. And it's so frustrating. They shouldn't have to. Like, they shouldn't have to say to their doctor, why are you telling me that I I've had patients that come to see me that are like, my doctor told me my LDL was fine for years and now they have triple vessel coronary disease. And I'm like, gosh, I'm so sorry. It's heartbreaking. And so I feel like the only thing I can do, with social media is tell people there are guidelines available for everything. And it doesn't mean that you are necessarily going to fit into that guidelines for X, Y, or Z. But say if you're someone, for example, the new gold rush of people to take advantage of is women of menopause, right? So this is now, now all of a sudden it's like, oh, we have a new area where we can take advantage of women with misinformation and sell them supplements and nonsense. It's huge.
Oh my gosh, it's crazy.
Highly recommend, shout out Jen Gunter. She's an amazing follow.
I asked her to come on the podcast.
She's phenomenal. She's great. And, but just for any subject area, you can find the guidelines and say, well, what does the North American Menopause Society say about, anything that you're seeing on social media? And then you can actually literally use it as a check and balance to see, oh my God, is my doctor a quack? Or is my doctor, making this up? If they're following the guidelines, it's great. If they're not, it may not be that there's an error there. It may actually be that for whatever reason you may not fit into that, but it's worth a conversation. And these are open access and available for everyone. I actually even hate that I have to say this, right? Like I hate that I even have to say, you should advocate for yourself and go to the acc.org and make sure that they're following the guidelines. But in this day and age, it's one of those things that being your own best advocate is like the ultimate safeguard. I saw a really heartbreaking tweet. I actually hate to even repeat it, but it made me a little sad. But it said, in 2025, the only reason someone tweeted this, and I was like, oh, soul crushing. They said, in 2025, the only reason to go to medical school is to protect yourself and your family from other doctors.
Oh my gosh.
And it broke my heart because
I honestly relate to that. So I've had such bad experiences with doctors.
It breaks my heart because
it sucks.
It's tough.
That really sucks. And I appreciate you because at least you're willing to have a discussion about it and be like, this is a real problem. Whereas other times if I bring it up, sometimes medical providers will be like, how dare you? We're so busy. I'm like, listen, I understand that you're busy.
And I see both sides because I think they are busy.
But that to me, it doesn't discount the fact that patients aren't getting the care they need. So it's like, I'm not looking to blame you necessarily.
No, agreed. I agree.
But maybe there's insurance issues. Maybe you're overloaded with stuff. Maybe there are a million other things. But that doesn't – listen, I could have a really crazy busy day if I'm a personal trainer on the floor for 12 hours. But that doesn't give me the right to treat you like shit, to not hear you, to not discuss, not do the exercises that are appropriate for you at this time. It's like, I get you're busy and I get you're dealing with a lot of shit. And I understand there are other factors at play as well. But at least you are willing to have the discussion and say, listen, it's not perfect and there are real issues we need to fix.
No, listen, our system right now is built in many ways to fail. And it's failing doctors and the patients. Because it's not like doctors that are working in the traditional healthcare system are like, this is so easy and rolling in the dough. Med school loans are insane. It's like, this, and they are like, they have, hospital systems which are run by an insane amount of administrators have their foot on their neck for seeing, you better see, one patient every 9 minutes, no doctor is choosing that. I think one workaround, I do not have the answer to this and a solution. I think one workaround, is there's different models. You can, find a direct care. You could find an out-of-network doctor. But if you are someone that wants to see a doctor that's in network with insurance, there's still, I think, one workaround that may not be 100% foolproof, but sometimes it's making multiple visits, meaning, okay, you may not get, if your doctor is, under insurance, they have 15 minutes for you for a follow-up. You may not get 15 questions answered at that time, but make a follow-up. Get all of your questions answered. And most doctors will appreciate that. I know most of my friends in primary care, as a specialist, we're luckier. It's a little more focused. When you see a patient, there's still tons of questions, but get those questions answered. And maybe it's not in one appointment, maybe it's not in two, but just keep getting your questions answered. Now, if they're dismissive, if it's not a time issue, but they're dismissive or they're demeaning or they're belittling, you have to find someone else. And just like doctors are not any sort of different kind of human, just like every other industry, just like every other profession, there's going to be good ones and there's going to be not good ones. We have to just advocate for ourselves. And truthfully, even if you're a doctor, I'm also subject to, every doctor is subject to, you put your lives in the hands of other specialists because, when we get old, God forbid, like I'm not a neurologist and I'm not like, if there's something that happens in a different specialty, I have no clue what the actual recommendation is. I do have, of course, resources and the way to kind of sort through their guidelines and things like that, but it's still incredibly nuanced. You put a lot of trust into physicians. And so I do think that it's a fair, evaluation to say that our system is not perfect. It's a mess, and people have to do the best they can to advocate for themselves. And one thing you and I discussed is that's probably why a lot of people fall into the alternative medicine kind of pathway, and they end up seeing a chiropractor or a naturopath who makes all of these recommendations. Is not because someone who has gone down that pathway is not smart. It's not because they're dumb. It's not because they have no idea what they're doing. It's because this person is offering them time, is going to listen to them, is going to hear them out, and is offering them solutions. And so I think that is the unfortunate thing, is because sometimes people will go, will be steered away from guideline-directed care. And it's because, like we mentioned before, they just want someone, to listen to them. And there's different ways to navigate that. And I think that if you in the traditional insurance model, then that way may just be multiple, appointments.
Yeah.
Until we have it figured
out. We're going to shift gears now to a topic I'm super excited about. And I've learned a lot from you about. You made a post showcasing how Zepbound, Tirzepatide, was associated with a 38% reduction in combined risk of cardiovascular death or worsening heart failure. You had a separate post discussing how Tirzepatide had been FDA approved to treat not only obesity and type 2 diabetes, but more recently, obstructive sleep apnea. Can you talk about the current known benefits of Tirzepatide and or all GLP-1 receptor agonists, as well as what you think it will be good for in the future?
Great topic. So I, as a cardiologist, I actually prescribe a lot of GLP-1 receptor agonists. So like whether it's Ozempic or Wegovy or Zepbound or Mounjaro, because even though people think of GLP-1 receptor agonists as aesthetic weight loss, as a cardiologist, the most important thing to me is how these medications reduce cardiovascular risk factors for both the primary prevention risk factors, like, help people to lose weight and improve their blood pressure, help people to change their dietary habits and improve their cholesterol, help people improve their hemoglobin A1C, as well as secondary prevention. So there was a trial called the SELECT trial, which looked at, it studied Wegovy, and they essentially randomized individuals who have coronary artery disease with a BMI greater than 27 with known coronary artery disease to being on Wegovy versus a placebo. And they found a 20% reduction in heart attack or stroke, which was really
Holy
tremendous.
Shit.
Major adverse cardiovascular events,
That's
right?
insane.
It's unbelievable. And then, you have, of course, Zepbound, which is incredible medication, leads to even more weight loss than Wegovy, but also is now FDA approved for obstructive sleep apnea. There are a tremendous amount of individuals who their sleep apnea goes into remission on this. I mean, the era of treating people with type 2 diabetes is completely changed, right? We actually now fall into this area where we have our little academic debates in cardiology. People that had diabetes that's now in remission, type 2 diabetes that's now in remission because of these amazing agents. The question is, well, where do they fall into the risk pool? Do they still need, that cholesterol medication if they don't have coronary artery disease? Now that their diabetes is in remission, this is a data-free zone, actually, right? And so this is a little bit more nuanced and academic of a discussion, but these medications are so effective and so incredibly powerful that, we're seeing improvement in outcomes across the board. Fatty liver disease. We're seeing improvements even with reduction in, acceleration of chronic kidney disease. So lots of different, cardiometabolic health and both, kidney and liver disease endpoints that are really valuable. And so I think that, when they became popularized, it was all viewed about aesthetics.
Yes.
And I always say to my patients, I'm like, I'm happy if you're happy, but to me, what makes me happiest is seeing, first of all, them have better quality of life, feeling, of course, better, being more physically active, making dietary choices that are more helpful for them. But of course, their improvement in their cardiovascular risk, that's so valuable, right? Especially now in this day and age where we now know that the vast majority of dementia, including Alzheimer's dementia, is caused by the exact same risk factors that cause cardiovascular disease. And so, we talk about not just living long, but living well, right? Because if you're 95 and you have no idea what's going on, the quality of life, that may not be what you want. What if we could say, well, what about if you're in your 90s and you're living independently and you have your mental faculties and you've been listening to Jordan and doing strength training and exercise and walking, and so you have good mobility and less frailty? These are the things. I think it's not just about how long we live, but the quality of life as well. And I think that's where GLP-1s also figure into the picture. I think also another important point too is thinking about the fact that, how wrong we got it about weight and metabolism, and how for so long we have, I hate to say it, but we've just talked about diet and appetite and things in terms of willpower. And, it's such a, I look at the way we treat obesity and individuals with overweight now, in very many ways, the way we treat things like genetic dyslipidemia. I can't imagine seeing a patient with familial hypercholesterolemia and telling them to will their cholesterol down, or seeing a patient with hypothyroidism and saying, will your thyroid to work, right? Yes, it's not identical, but actually when you look at research from metabolism scientists, people like John Speakman and all these tremendous researchers, you'll see that there's quite a lot of genetic link actually. And it doesn't mean that everyone is destined to be, one weight their whole lives, but the food environment has changed and there's so many, it's multifactorial, weight and metabolism and the way our interaction with the food environment, there's so many factors at play that it's not to say the whole world should be on a GLP-1, but it is to say that it's a tremendous advancement in science that can have a tremendous benefit for many people. And, the destigmatization of it is important as well.
So, which leads us directly into, I have to ask, what did you think of my GLP-1 experiment? Which, by the way, and I know we spoke about this previously, but I was like, you're welcome to disagree with me.
Wait, so I didn't watch the whole thing.
That's fine.
I feel like I saw your post and I just said, oh, I'm happy to hear that from you, but I didn't deep dive. So sorry, I am like a little absent sometimes from the internet.
I'm jealous. It's
I'm
amazing.
Trying to get into mountain climbing. So I feel like I'm on this whole new venture of education I won't bore you with. But, I also started ballet. I have a lot of things.
I saw that. It's amazing.
Well, please. So I'm also starting to stay with strength training because Jordan made me, but no, please, no, can you just run me through? I just was excited for you. And I was like, yeah, go you. But can you run me through
Well, it's funny because I posted about it and then you left a comment with the clappy hands.
Yeah.
And someone replied underneath you. And I'll say this, the overwhelming response, Danielle,
positive.
Oh my gosh. And I think for many reasons, not least of which I think the number of messages I've gotten, hundreds, if not into the thousands of people who are saying, I've been secretly taking it because they feel judged.
Right.
And so the number of people who are like, oh, like this is an option for me. I'm type 2 diabetic. My doctor has been saying it, but I've been resisting it, The overwhelming response has been outrageously positive. Teeny tiny small percentage of people have been really angry and posting about it on social media. And it's like, fuck you, whatever. I don't care. But you did the clappy hands. And someone was like, to the effect of, oh, wow, like, do you support this even though he doesn't, quote unquote, need it?
And I wrote, he's not my patient. I don't know whether or not he meets FDA criteria for the medication. That's none of my business.
So with that in mind, and we'll link the GLP-1 experiment in the show notes and underneath the YouTube video. Basically, so there were a number of reasons why I wanted to try it.
Yeah.
And I've done many, many experiments in the past. But first and foremost, I like to try things that my clients are going through. I've always found it's one thing to read about it. It's one thing to learn about it. It's another thing if I actually go through it. So that was one reason why I really wanted to try it, so I could better understand what clients are going through. The other reason that I've been overtly honest about this since I got into the industry is so I was wrestling from 8 years old to 18 years old. Oh. And I developed severe binge eating disorder, anorexia, even bulimia as a result of it. And thank God I haven't had a binge in close to 15 years now.
Wow.
But that to say that like there hasn't been extra food noise and issues around food isn't accurate either. And I've been overtly honest about that.
Right.
So I spoke with my provider and I was like, this has been something I would like to try. And they also looked at my blood work and looked at everything. They're like, listen, like I have no problem having you try this on a very low dose.
Yeah.
And holy shit, it's been incredible. It's been an incredible experience. I not only has it been beneficial for me for the first time in my life, my cholesterol being in a healthier range. Not only have I like I don't feel a drop in energy. Like overall, I feel great. Health markers radically improving, and it's helped me so much more as a coach to better understand not only clients who are going through it, but also then to speak with people about the potential concerns. It's been able to help me educate myself more on it, just with practical experience. So for me, it's been wonderful.
Gotcha. I mean, I think that's super interesting. I've never been on a GLP-1, but I prescribe them quite a bit. I probably prescribe more GLP-1s than in Cardiologist in California. That being said, I think that there's clearly for you personally, like when you have that decision with your doctor, shared decision making, I think that also, I mean, I'm glad that you are destigmatizing it, but at the same time, I think that, for people to jump on and judge you, I think is not fair because that is a decision between you and your physician, right? You're not doing heroin, okay? So, and so like that's a shared decision making, whether or not, I'm not even going to ask you, it's none of my business, whether it's on label or off label, this is your business. This is a decision you make with your physician. And so I think people who jump on and judge and say things, I think that they may not understand. You could have a variety of reasons that, like you just mentioned, health-wise, that may have a benefit for being on it. That being said, when we have this discussion with patients, when you're talking about the FDA-approved medications, when someone is using it, whether they're using it, on label, or off label, it's two different discussions because, of course, when you can give a patient the information like, well, we will expect these kinds of side effects or these kinds of benefits, that's based on the clinical trials we have, which is studying a certain subset of a population. And I guess, when you have that shared decision making with the patient, so I'll tell you about a population that I often use it, quote unquote, off label in. For people who are South Asian, actually, there's a very high cardiometabolic, we know, genetically inherited risk. These people are Indian, South Asian, things like that, at a lower BMI compared to white or black people. And that BMI is 23.5. The World Health Organization considers overweight for individuals who are South Asian at 23.5. And you'll actually see any doctor who's listening or, anyone in healthcare, you'll see that these individuals, they have such a lower threshold for visceral fat where they start to develop prediabetes, dyslipidemia, all of these things. And so I have this shared decision-making, discussion with patients where we say that this is off-label use of this medication. So the risks versus benefit ratio may not directly apply to you because you have not been studied. Now, your risk of prediabetes or your risk of, your metabolic dyslipidemia, you may benefit from being on the medication, but there may be more risks depending on the individual. That's a shared decision-making process that goes into, we have to wait until that subset of a population is studied to give them that definitive benefit risk. But at the end of the day, it's a discussion with your physician. And, even though the majority of our use, of course, is on label of these medications, but there are certain scenarios, this is where guidelines come into play. Guidelines are there for a reason, they're rubric, but then remember, it's also the patient sitting in front of you, their goals, their preferences, their individual risk, their individual, history. And for some people, that's going to look different. And that's where you have to just evaluate the benefits, the risks, have that discussion, and do what works best for that individual. And I think that the issue is I think too, is that as time goes on, I think that, people really have made weight into this willpower only thing.
Yeah.
And I think that there's like a lot of, areas in the like health. I mean, I wouldn't even say the health industry. I would say just the general public that have been like, it is your fault if you struggle with appetite or weight. And, I think that is just so, it's been prevalent throughout your and I's entire lifetime until now. And I think that it's just such a nice switch to see the blame be less on just the individual and And truthfully, as you know, I'm sure when you've experienced being on it, I always say, actually, I'm working with a team on a research paper on this about the dietary interventions that can help people reduce side effects when they're on a GLP-1 receptor agonist, that it also is not a magic cure, meaning if
Correct.
you eat a lot of foods that are going to delay gastric emptying, if you eat foods that are really high in saturated fat, if you eat a really low fiber diet, you can have a tremendous amount of side effects on a
Yeah.
GLP-1 receptor agonist. You can't just go on a GLP-1 and say, I am done, call it a day. Actually, you get direct feedback from your gastric tract that tells you
Immediately.
immediately, you cannot eat this. You will get constipated. You will have intractable nausea and vomiting. And so there's this also idea that it's this cure-all, but anyone who's on it knows that's not the case. You still have to do the strength training. You still have to do your exercise, get your steps. You still have to eat a healthy diet. It's just a tool in the toolbox to help people get there in a way that they otherwise may have struggled to.
I think it's been really interesting. Again, going back to behavior change and all of that, the fitness industry has come very far in understanding that guilt and shame is not usually a good strategy
Right.
to get people to change. But GLP-1s brought it out of people again, where as soon as GLP-1s come into the picture, so many got on their high horse and guilt. Not, and I'm not talking about me. Like
Yeah.
I don't. I've got thick skin, whatever. But like as soon as GLP-1s become a part of the discussion, there's even a woman who very kindly posted my inner circle who was just like, "Hey, listen, I'm considering this, but based on my BMI, my doctor isn't sure." And the vitriol and the bullying that came from this one other woman who I almost kicked out of the inner circle. I made it really clear. I was like, "You are not. If this happens again, you're out." She's a coach. She's a
Yeah.
coach who came in being like, why do you think that this would be worth it for you? Like if you're not in the BMI, which I actually want to talk to you about that. And I'm glad you brought up how different cultures have different BMIs that maybe, what do you, BMI, I feel like can be a good tool. I think we can all agree
It's a
on that.
tool. Yeah, it's a gross
But-
estimate, but
but-
it's not like the ultimate, best decider.
I found it interesting that generally in the fitness industry as well, we agree BMI. In the fitness industry, people hate on BMI.
Of course.
They hate on it because they have more muscle. They're
Right, of
often
course, right.
out of it. But then now when it's come to GLP-1s, they're all of a sudden being like, well, you're not in the BMI yet. So now they're defaulting to BMI, even though in other cases they're like, well, BMI sucks.
Yeah.
So where do you fall on that?
Yeah, so the medication has clear FDA approval. So what is an FDA approval for a medication? When we're being truly evidence-based, what does that mean? Well, it means that you can only have a true risk-benefit discussion if the patient is represented in the trial that was done, right? So if you're talking about putting someone with a BMI of 19 on a GLP-1 receptor agonist, that's obviously sounds incredibly unreasonable, right? Someone who does not need to lose weight, you're putting them on a GLP-1 receptor agonist for weight loss. If they have type 2 diabetes, that may be a different story, right? Obviously, because they're FDA approved for type 2 diabetes, regardless of BMI. But that's still a discussion to be had. Now, that being said, the medications are studied and FDA approved for a BMI greater than 27 with one or more weight-related comorbidities, or a BMI greater than 30 without any comorbidities. You can have comorbidities as well, but you just need to be a greater than 30. Okay. So what does that mean? That means that these are what the clinical trials were designed around. Does it mean that it wouldn't work for other populations? No, but we just don't have that data. So with regards to quote unquote off-label use, it has to be as reasonable of a discussion of benefit versus risk as possible. We really can only endorse the on-label use of GLP-1s with regards to the meeting the FDA criteria, being above that. But will I say that every single doctor? I just mentioned a population. So like, for example, South Asian individuals who the World Health Organization considers them overweight at a BMI greater than 23.5. So although they were not studied in particular in these studies at that BMI, they are considered overweight, right? And so that compared to white or black people at that same BMI.
That's super interesting.
It's super interesting. And they have a ton of higher risk with cardiometabolic disease and with prediabetes and things like that. So that's where shared decision-making comes in, right? So if I have a patient who maybe their BMI is normal and they have very elevated glycemia, they're almost at the range where they're going to reach, type 2 diabetes. They have a significant family history of type 2 diabetes. What's really interesting about type 2 diabetes is that oftentimes it does improve with weight loss. But actually, I used to think before I started medical school, type 1 diabetes is the genetic one, right? Well, yes, that can be genetically linked. But actually, the allele for genetics on type 2 diabetes is actually very strong. There's actually quite a large, genetic link for type 2 diabetes in families. So sometimes you could see individuals who are getting close to getting type 2 diabetes, but their BMI is not at 30, right? It's not even 27. So these are discussions you have to have with your physician. And as I mentioned, it's shared decision making. It's not so black and white. But yes, the only thing that can be endorsed, of course, like officially, is the, FDA approved medication at the FDA approved indications, BMI greater than 27, one or more weight-related comorbidities. That may expand with future studies. The FDA labeling may expand for, once randomized controlled trials are done with regards to things, like binge eating disorder. Maybe that once randomized controlled trials, if they demonstrate benefit, maybe that will be a use.
That seems to be a popular off-label use right now.
Absolutely, yes. And so there's I think that there's just, in medicine, there's always off-label use of things, right? We've historically used things off-label for a variety of indications, but it doesn't mean that it's perfect. And sometimes you have to also use caution. There can be harm, right? So it has to be a shared decision making, and to be the most evidence-based possible. Sometimes for one individual, it may have more benefits, but it may have more risks. So that's why, I do think that this is also an area with a lot of movement. I don't think the jury is out, right? There's going to be more trials, I'm sure, looking at different ranges. And like you mentioned with regards to BMI is tricky. It's not perfect, right? In an ideal world, we'd have everyone getting a DEXA scan. In what world can every person pay to go out and get a DEXA scan?
Right.
But we all know that a BMI of 27 is someone who's lifting weights does not, and that has a ton of muscle mass doesn't mean the same as someone that's not doing any exercise whatsoever. So yes, none of us are blind to think BMI is like the most perfect, right? This is medicine. This is science. We know that in general, we cannot have a massive population DEXA scan because just not everyone's going to be able to afford to do that. So, it makes a difference as well. So, keeping in mind, there's so much nuance and there's context. It's context dependent. And for you, whether or not you were on label or off label, if you found that your decision with your doctor was that it worked for you and the benefits outweighed any potential risks, that is something that is your decision. And I think that, I'm glad you shared it with the world so people could live through your, experience and understand it. But at the same time, your personal medical history is none of our business at the same time. And so I think it's, valuable for people to have that discussion with their doctor. There, of course, I can't say that without the caveat of saying that there's some off-labeling use that are dangerous. People with a history of anorexia that may take it too far and then worry about their bone density loss, There's something in medicine that we have to use as doctors too called common sense. And I think that also is a variable that unfortunately is sometimes in shortage.
Yeah, that's all fair.
Yeah.
Thank you for that. That was super helpful.
Yeah.
If you were to play Nostradamus and look into the future of GLP-1s, where do you see these drugs going? Where do you see population-wise people? Like, what do you think happens large scale?
Oh my gosh, imagine. I think the future is bright. I think that the technology is getting better and better. I think that, I think bariatric surgery has incredible benefits, and I give so much respect to our bariatric surgery colleagues because there's the best, data is actually from bariatric surgery. But I do think that we're going to see a time where that is obsolete. And I think that is going to be all medical therapy. Look at cardiovascular disease. In 2019, we had the ischemia trial, which showed us they randomized people with coronary artery disease outside of left main disease, people who had a normal ejection fraction, so no heart failure, and they randomized them in the ischemia trial to either guideline-directed medical therapy and these are people with a positive stress test. So they had either a stress test or CT that showed ischemia, okay? Which traditionally would be people you would generally stent. And they randomized them to guideline-directed medical therapy versus guideline-directed medical therapy plus a stent or guideline-directed medical therapy plus a bypass. And guess what it showed? It showed that there was no difference. And so people that we would put a stent in, 10 years ago are people now we're managing with medical therapy.
That's amazing.
Yeah, it's incredible. It's incredible. It's not to say everyone. That excludes left main disease, that excludes heart failure, that excludes diabetes with certain vessel disease. There's a few still guideline indications for revascularization. That also excludes people with symptoms. If you have chest pain that does not respond adequately to medical therapy, you may get a stent. But the stent, even for symptoms outside of an acute heart attack, a stent does not save your life. It's used for symptoms. It doesn't improve mortality. Only in the setting of an acute heart attack is it mortality benefit. But otherwise, when it's used symptomatically, it's just essentially palliative. It's for symptoms. And the mainstay for everyone across the board is guideline-directed medical therapy. So I think with GLP-1s, probably we're going to see something similar. We're going to see procedures, maybe fall behind the medications that are less invasive. And then I think we're also going to see medications are going to improve. I mean, the equivalent, I would say, in cardiology is we now have a medication called inclisiran, which is an mRNA medication which lowers your LDL cholesterol, and it's dosed twice a year.
Shut up.
Yeah, it's like an LDL vaccine, essentially.
That's incredible.
It's incredible. It's life-changing because you know that over 60% of people who are prescribed cholesterol medication just are not adherent.
Yeah.
And if you can, anything like you mentioned before, which was so beautifully said, anything that reduces the barriers to adherence, anything that makes things easier for patients is a win.
100%.
And so I think we're going to see the same thing with this advent of medications, things that are longer acting or more effective. And I think longer term, probably after you and I are dead, maybe we will see that with GLP-1s, the food environment will change. And then maybe once the food environment changes, we won't need the medications. Who knows?
Wow.
But we'll be dead.
But we'll be dead. That's a really interesting prediction. Right? That's really interesting. I know that
the food environment's already starting to change.
I know that the food companies are pissed about the GLP-1s.
Now they're coming out with GLP-1 snacks. Yeah. Oh my God. It's like,
the marketing never stops.
Never stops.
All right. So let's move on. I want to talk about your strength training.
Okay, this is an ode to Jordan Syatt.
So tell me the story. Tell me the story of your strength training.
Everyone needs to hear the story. I've told Jordan this many times. He probably forgets because he gets so much praise, but I'm going to tell everyone this story. I have always been a cardio fiend, and I've always done sports my whole life. I did soccer competitively. I did downhill skiing my whole life. I still ski, and I raced, and I've been a runner. I've done marathons. I've done triathlons. I've done all the things, and I've always hated strength training. I've despised it. I've always felt I've done everything. I've gotten a trainer. I've done at-home strength training. I've watched videos. I've done all the things. And I always hated it. I was like, well, maybe if I had an interesting trainer that was fun, I would like it. No. Maybe if I did it with, my friends, I would like it. No. Maybe if I did a class like that has strength training in it, I would like it. No, I've just always despised it. And then I had you on my podcast back in the day, and I explained to you that, gosh, the data for resistance training, for women, I'm in my 30s. It's like when you get into your 40s, you really want to just start building. You want to make sure that before you get older, you want to build lean muscle. It's so important for longevity. Cardio is, of course, important. But now we really have a tremendous amount of data that shows us that, resistance training in combination with other physical activity, walking, cardio, things like that, it's really the best of both worlds. The data is undeniable. And I was like, Jordan, how do I make myself do it? Because I hated it. And I had tried and nothing would stick, okay? And I made it through 10 years of working a gazillion hours a day, all of these things, and I couldn't do it. And you said, you need to practice acceptance and you need to just accept that you hate it and just do it anyway. That worked. And that was 7 years ago, maybe 6 years ago that you and I have had this conversation, and I have not given up strength training ever since because you said that to me. Because what happened was I did it. I just said, he's right. I hate it. And I accepted that I hated it. And I did it anyway. And I just said, this is just, you know what? I'm going to just do it. I started out 30 minutes, 2 days a week. And I made it as convenient for myself as possible. And I found a trainer that was near where I lived. And I was like, okay, I'm just going to do it. And then I went up to 3 days a week. And then I went up to 4 days a week. And then I did an hour. And so I just accepted that I hated it. And do I absolutely love it now? I do not. Okay.
Good.
I do not love
Good.
I do not love it, but do I hate it as much? No, I hate it less. And the reason why is, one, is because my trainer is very nice. But two is because I've seen it like yield results in other areas. So I started in January ballet. I never took ballet ever in my life. And I was like, I want to start ballet.
You need to be strong to do ballet.
First of all, ballet is shout out to all of the, your listeners who have done ballet. You guys are the ultimate athletes.
100%.
The ultimate.
100%.
Like, unbelievable. It is so hard, both mentally and physically. It's in another language. I'm like, oh my God.
It's a great way to put it.
And your brain, like it's the hand-eye coordination, it's the balance, it's the strength that it requires. I felt like my strength training helped me so much with learning ballet. It's made me a better skier. It's like, it's made me I'm getting into mountain climbing now and hiking. It's found its way to increase my ability in other ways to enjoy other things because I just love physical activity. And I think that the biggest hurdle was this myth that I believed for so long was that you have to love it. You have to love exercise because then I kept being like, I don't love it and I want to quit. But when you said just accept it, that was actually life-changing for me, just so you know.
That makes me super happy.
Yeah.
That makes me super. And that it goes back to the behavior stuff. I'm like, what can I say that's going to get people? And listen, I used to say it, like, I remember 2013, 2014 making posts being like, you just have to find the one that you love, da da da. But it's like, the truth is, sometimes you got to do shit you don't like.
Yeah.
And not everyone is going to like strength training. In fact, I would venture that majority of the world wouldn't actually enjoy being in the gym strength training for an hour, 4 days a week. Majority.
Right.
If they did, we wouldn't have so many of the health issues that we have. But understanding that you might not love it, but you got to fucking do it. And so how can we do it in the way that you hate it the least?
Hate it the least. And so I felt like that was literally, I'm telling you, it changed my life because that was the only advice that I was like, I felt like I actually had no excuse to myself because like, it wasn't like, well, I hate this kind, so I'm not going to go to this class, or I hate this activity, so I'm not going to do this. Instead, it was like, well, Jordan said, I'm going to hate it. Just accept that you hate it and just do it anyway. Yeah. So I put it on my schedule, like going for a dental cleaning. Like, to be honest, actually, I love going to the dentist for cleanings.
Do you really?
Yes, I actually like go out of my way to go 3 times a year because I love it. Okay. Cardiovascular health and dental health are related, but I truly enjoy, there's nothing better than coming home from the dentist after cleaning. I love it. But like, it's analogous to, like, you just tell yourself, like, this is something I don't like, but I have to do it. And then like, that really changed my mindset. It was so valuable for me. I'm so proud of you. Rather than being on this unending hunt to find something I love so much. Because it also changed the expectations of it. Like, I don't have to love it. I just have to do it. And it's actually kind of made me, I still don't love it, okay? I'm not going to be starting a strength training account, okay? Because everyone would be like, you can't lift that much anyway. But I'm getting stronger. I can open jars, I feel
That's
like
what's important.
My dog's a beast and I can hold her on the leash, which is valuable because she's so strong. But like the little things, right? It's like, and
we talk about, it's funny, we joke about opening jars, but that's like an actual really important measurement of
grip strength.
Yes.
It's related to mortality. I know I used to be in denial about that before. I was like, my grip strength,
whatever.
I can't open pickles. No, it was really the most valuable advice you gave me. And it really is just, it's just a mindset change.
Yeah, I'm glad. Do you measure your bone density? Do you get that?
Yeah,
taken?
so the last Dex I had was probably a year ago. My bone density is good. I'm still trying to build muscle mass. I'm like a little lean, but I'm still trying to build lean muscle. But like, it's one of those things that like, it's also, my issue is also with regards to time. So like, I love so many activities that's trying to balance like the increase in strength training that, and even like the increase in eating enough and all these things that like balance with like all these other activities that I do. Like it's hard because I do love exercise. So it's like less prescriptive for me.
Yeah.
But yes, my bone density is good, but I always want to keep building muscle, especially like, as we get older, it's so important. Do you do DEXs frequently?
No.
Yeah. I've only done one. And I was just curious, but
I'm going to give you my hypothesis.
Yeah.
That it's not studied, but this is what I think.
Tell me.
And this would be a very unpopular opinion in the strength world.
Okay.
We know how important building muscle is, and really what I think we know is we know how important building strength is.
Strength, yeah.
Which is different. Building muscle, building strength is different.
100%.
As ballet will teach you.
Agreed.
As gymnastics will teach you. And I always say, like, people ask, what's the number one sport a child should get into? Gymnastics. Like, gymnastics, like,
amazing.
But ballet and gymnastics are similar. They're very similar. And my hypothesis is that as more science and more research comes out and evolves, we'll find that, because we know, for example, that just building muscle on muscle on muscle on muscle
100%.
is not always a good thing.
I know where you're going with this, and I fully agree.
And so I think that what we're going to find is strength is a much more important indicator as opposed to simply muscle mass.
Right. And I think it's actually also, I think you may end up being right. I think your spidey sense on this may end up being right. I also think it's also depends on body composition as a whole, right? So just building an unending amount of muscle may not be necessarily beneficial.
Correct.
Right? Versus
this is a very unpopular thing to say right now.
Oh God. All right. I'm going to get tomatoes virtually thrown at me. But just building an unending amount of muscle, like what research do we have that just like having an exorbitant amount of extra muscle mass is beneficial versus like the comparison of your visceral fat and bone density and all of these other metrics? Do we have to be all super jacked? Of course not. I don't think we have research that shows that we have to absolutely be, super jacked. And I think that you're right. I think that's a really interesting hypothesis as well. And I think that, the pendulum always swings, right? So like I'm super into cardio and I love watching your journey being like, you do like getting your steps in and all this stuff. You're not just about strength training.
No, I do everything.
You do everything, which is
mobility
great.
And strength and cardio and everything. I think too many people pigeonhole themselves into one camp. This is what I do. And it's like, why? Why is it just one thing? It's like you only read one book for your whole life. Right. It's like, what, or even just one genre. Like, I don't know, branch out a little bit, try something new, challenge yourself. That's why when I saw you doing ballet, I was like, fuck yes.
That's so challenging.
Holy shit. No, ballet is a bitch.
Oh, it's incredibly difficult. I have so much respect for it. And it challenges your brain in a different way, your balance, your coordination. Isn't it fascinating when you see someone that can lift a zillion pounds, but they can't run half a mile?
Yeah.
They're winded. They can't do, I actually get concerned sometimes prognostically. Like someone can lift a gazillion pounds, but you put them on the treadmill for Bruce protocol, which is actually a really good prognostic indicator.
Yeah.
You go on the treadmill for greater than 10 minutes on Bruce protocol. And this is at an inclination where the speed is raised. The speed and the incline is raised every 3 minutes for a cardiac stress test. And, the prognosis above 10 minutes is really great. But depending on how old you are, the prognosis under 10 is not great. And, I have seen people that are these bodybuilders, et cetera, that are like winded and out by 5. And I, you venture to say that just because they physically look muscular, et cetera, does not mean their cardiovascular health is, at where it needs to be. So I think that the same with our cardiology guidelines for exercise. We recommend a combination, right, of both cardiovascular exercise, aerobic exercise, as well as strength training, because like you said, it's not just one area that's going to be the end all be all.
We see a lot of issues with people in the fitness industry basically saying you don't need cardio, you just need to lift weights because lifting weights gets your heart rate up. I'm like, that's not what dictates the benefits of heart health is your heart. If all you needed to do is get your heart rate up, watch a scary movie.
Yeah.
It's not purely based on just getting your heart rate up for a sustained period of time. And if we're looking at the energy systems used, you need a sustained amount of time. And a heart, it's not just the heart, it's the lungs and what's contributing, and also what's going on within the muscles at the mitochondrial level that actually leads to these cardiovascular improvements. It's looking at just your heart rate. Yeah, you do a set of heavy front squats for 5 or Bulgarian split squats, your heart rate will go up.
Right.
But then it'll come back right back down. Right. And it's a different energy system, completely different demands on the body, and which is why, like, listen, if all you're doing is strength training, it's great, it's better than nothing. But you have to get some cardio in. Yeah. It's like, and I would say the lowest hanging fruit would be steps.
Yeah,
just the lowest hanging fruit.
Such a good one. That is such a good one. Steps are great, actually.
They're amazing.
Yeah.
It's a great time to if you have a spouse, connect with your spouse, or listen to a podcast, or make phone calls. Like, it's amazing.
Yeah, and anyone listening, if you ever have seen a cardiologist for whatever reason, you may have heard them ask you this question, which is, do you ever they'll say, do you have any chest pain? Do you have any shortness of breath? Do you have any dizziness? And they'll say, no. Okay, well, what do you do for exercise? And they say, oh, I do, I walk or I play pickleball or whatever. You say, do you ever have shortness of breath or chest pain when you go up the steps? And it's because someone may have no symptoms at all on flat land or, walking around, going to the grocery store. But walking upstairs can trigger symptoms. And that's, something that we have to investigate.
That's interesting.
Right. So it's a good stress test for yourself. How are you doing up a couple flights? Are you winded? Well, one is, of course, talk to your doctor. If there's any sort of cardiovascular risk factor there, you may need an echo or, cardiac CT. But otherwise, it may just be a signal like, oh, okay, maybe I'm not in as good cardiovascular shape as I should be.
I want to move on to an important nutrition question.
Yeah.
So you're vegan.
Yes.
You're an ethical vegan. And one thing that I know many people struggle with, but especially plant-based vegans, is protein.
Yeah.
And I'm wondering, as a vegan, how do you get enough protein?
Yeah, so great question. So I will say that as a physician who's vegan, I've been vegan for like many years, over a decade. I will first say that in patients that are not suffering from like a chronic disease, like malabsorption or cancer, we do not see protein deficiency commonly in the United
This is
States.
also an unpopular thing to say, but it's so true.
It's so true.
It's so true.
And so there's protein in plants. People forget that. It is really something I have to remind people of once a year. There's protein in plants. And even the myths about protein combining are completely false, right? You get all of the amino acids you need from all of the different kinds of proteins. And this isn't based on vibes. This is based on...
If they've made it this far in the podcast and think all your information is purely based on vibes, and they didn't listen at all.
It's based on randomized controlled trials.
You told me like we can't do the blood thing because it has to be studied in an RCT. So I was
and so it's based on trials. And so what do we know? Well, first of all, we know that you can get adequate protein on a plant-based diet, of course. But I will hedge to say that one of the things I'm really glad about not being dogmatic is that actually people say, well, since you're vegan, and since included in all of the guidelines and your own paper says a healthy plant-based diet can be recommended alongside a Mediterranean diet and a DASH diet and all those other plant-predominant dietary patterns, people say, well, why don't you push that? And I say, because actually, to be on a very healthy, well-planned plant-based diet takes a lot of planning, I think. And I actually think it's irresponsible for me to just tell everyone, just go vegan. Because you do want to make sure, just because something's just plant-based, I mean, French fries and Oreos are vegan, right? So like, it doesn't necessarily equate healthfulness, right? And so how do I get a good amount of protein? So first of all, how much protein do we need? So if you look at the RDA for protein, it's 0.8 grams per kilogram body weight. And then you look at, well, maybe that...
Can you transfer that to pounds just so people...
So kilograms to pounds, you have to just divide by 2.
Yeah.
You can type in whatever your weight is. Say if you weigh 160 pounds, do 160 pounds to kilograms. You can do the transition, but it's 0.8 grams per kilograms of body weight for the RDA, so the minimum amount. Now, I would say if you look at a lot of the nutrition science research, and I think the vast majority of scientists in this space will agree with this, probably a safer bet for a minimum would be 1 gram per kilogram body weight. But one thing that is very much agreed on, and for sure, is that if someone's eating 1.6 grams per kilogram body weight, and they're eating all plant protein versus 1.6 grams per kilogram body weight, and they're eating animal protein, as long as that person eating plant protein is getting 10 grams of leucine a day, which is super easy if you're eating tofu, tempeh, any sort of things with
basically
leucine.
Any plant-based person would be eating those anyway.
Yes.
Like, yeah.
The muscle protein synthesis is identical.
Yeah.
And so the truth is the best, kind to eat is the one that fits best into your dietary pattern, but ideally is lower in saturated fat. And, there's things that are plant-based that are high in saturated fat. Coconut oil. We do not recommend going to town on coconut oil. It's super high in saturated fat. And so, but you can get that from plants. I will say that when it comes to lipids, one of the little benefits of plant protein is that generally, maybe like legumes, things like that, lower in saturated fat, of course, and then also it's high in fiber.
Right.
So then you kind of get like a double, whammy for that. But, that being said, it's fully possible, but, it just takes a little bit of mindfulness. And I think that the misconception that I don't want people to have is that just abstaining from eating animal products equates health, because that's not the case.
Do you take protein shakes?
I love protein shakes.
Which ones do you take?
Okay, so I am not sponsored. I have no affiliation with this brand. I pay for it like everyone else. I love Huel.
Okay.
And so Huel, so my dietitian, shout out to my dietitian who works for my practice. He's a research scientist at Berkeley. He's a PhD RD named Kevin Klatt. I sent Kevin on the mission. I was like, you have to find for me what do you think the best? I valued all the amino acid composition and everything of all the different plant-based proteins, and he is like a brilliant dietitian, and he's a PhD scientist, and he really was like, I really think it's Huel. I'm sure there's a ton of other really amazing ones.
Yeah.
I just happen to love it.
Yeah.
And
you actually like the taste, because that's the major issue.
I love the taste.
Okay.
I love the taste. I absolutely love the taste. Can I tell you my morning smoothie?
Please.
Oh my God. Okay, I'm going to just say it. I love Huel so much that so I do like my morning coffee. I used to be a hot coffee person. And then I switched to, I make myself like a protein smoothie in the morning where I do espresso. I will not name how many shots to avoid being judged. I do espresso shots from my machine. I do 2 scoops of Huel, chocolate or strawberry. I do ice. And then I put in vegan Nutella, a scoop of vegan Nutella.
Oh.
And then I blend it. And it's like I get like however many 40 grams of protein, fiber, my coffee, and like a little something sweet. And
That
it's
sounds
like
delicious.
it's like rocket fuel with protein in it in the morning. And it's like a culotta, like remember old school, like
Yeah,
Dunkin' Donuts?
of course.
But just a little bit of vegan Nutella in it, just like a little bit. And that's like my
Like a teaspoon or a tablespoon or
like an eyeballed, I'm nervous to say. I feel like the anti-sugar people are going to come for me. No, like a little, like
the anti-sugar people don't listen to the podcast.
Okay, go.
They're not
like a
gonna
little
be here.
scoop, like a little scoop.
Okay.
Do
Do you know the calories in it?
I actually don't count calories
That's
for
okay.
me personally.
Cool. That's great. You say that like you're disappointed in yourself.
Yeah, I just
It's a wonderful thing. Like great.
I
you
guess
don't
I
count.
could calculate it, but I don't. Yeah,
Cool. Did you ever in your history?
I've done like experiments. Like I've been at the same weight for like, most of my adult life. So like I've done little experiments for like I did a vegan keto diet once to see if my LDL would change or
So you do experiments too.
I have before. Now I've like lost the energy to,
I feel you.
I just am busy, but like I think it's great that you do it. I love the N of ones. It's like informative and it's fun to watch someone's journey with it. But I actually have done like even intakes for myself. Like I always tell my patients like, because I love things like MyFitnessPal. I think it's so valuable to like sometimes just do an intake. Well, you actually it's so valuable to use an app where you can track things if you're going to make a measured change. So you're like, if I tell a patient, try to get your fiber up to 40, 60 grams of fiber daily, try to get your saturated fat less than 7%. I mean, how can you do that if you're not tracking, right? Like it's impossible. You can't just like know that inherently.
No one
That's
knows
like,
that, yeah.
you don't have an intrinsic Excel sheet in your brain. And so I've done like a little bit of like a check-in here or there on MyFitnessPal to see like, oh, am I getting how much protein am I getting? Like, what is my fiber up to? I eat like 90 grams of fiber a day.
I love
which
that.
is a lot.
I need to get on your level.
There's no upper level. There's no upper limit of fiber intake. I tell people it's the maximum you tolerate and enjoy, most importantly. You have to enjoy your diet. But I do not pay much attention to calories. But
Cool.
Not to say calories don't count, they do. But if you're not doing specifically for weight management, I don't focus on that number much.
I'd also imagine it's really hard to overeat when you're getting that much fiber and sufficient protein. Like,
So true.
It's really difficult. And when you're keeping saturated fat down, like
Yeah.
you're basically setting yourself up to not have a high caloric diet.
Yeah. Like it's, and that's the reason why I say like, when people say like, well, I've had success with weight management or X, Y, or Z on the carnivore diet or the keto diet or a vegan diet. And it's because all of them are natural elimination diets.
Yeah, exactly.
You're just limiting what you can eat when you go out in the world. And now, thankfully for vegan, I can eat vegan junk food too. So I feel like I can also partake, but it's an elimination diet. And so, yeah, I think that's probably one variable of it as well.
I have 4 more questions.
Okay.
Starting off with health and longevity. What is the one health habit, if you could only choose one, which I hate this question, but it is what it is. If you could only choose one habit that you'd tell everybody, sedentary or active, to adopt for a longer, better life, what would it be?
Is it something to do or something to not do?
You decide.
I would say no tobacco, no smoking, no vaping.
Love that answer.
Yeah.
It's just
Across the board, no smoking cigarettes, no vaping, no tobacco of any kind, chewed tobacco, anything. I would say just no smoking. We've really come to a time period where there was like a period of time in like our generation where like smoking was like very uncommon. It was kind of almost like frowned upon. I remember smokers like trying to hide it.
Yeah.
And now there's like a weird, odd resurgence. I'm seeing ads with people smoking cigarettes, and I'm seeing like some Gen Zers like smoking, and it's kind of like people aren't judging them. And I'm like, oh, no, no, no.
Yeah.
We cannot go back.
Especially vaping, I feel like.
And vaping, it's just not beneficial. And I think the thing for anyone listening too is that it's highly addictive. Do not feel like you need to target this alone. There are literal medical therapies like varenicline. There's all these, there's protocols with like nicotine replacement. A doctor could, with robust data for them that help people with cessation, with smoking cessation, with vaping cessation. You don't, of course, if you can go out alone, that's great too. But if you ever feel like you hit a wall and you're like, I keep, falling back on there, partner with your doctor. They can help you. I would say smoking cessation, reducing, not vaping. These are the biggest things, I think. And then second to that would probably be alcohol reduction.
Yeah. You were saying nicotine replacement.
Yeah.
Is tobacco, because I don't know this, is tobacco in and of itself addictive, or is it the nicotine that often comes?
It's the nicotine.
And would you rather them just have pure nicotine as opposed to
Well, you
tobacco?
use nicotine replacement in the when you are essentially trying to help someone titrate off, depending on how much they smoke or vape a day, will depend on the dose of nicotine replacement that you recommend, and then you try to titrate them off.
Okay.
But it depends, because if someone's smoking a pack a day, they're going to start off on a higher nicotine replacement than someone who's smoking like 2 cigarettes a day, or, and I don't know the quantity exactly of the vapes, because I think that depends. But there is like a way to essentially, there's like kind of an algorithm that you follow with regards to it. There's also all these myths that nicotine is good for you and beneficial, like nicotine in and of itself. And that's also based on a lot of, pseudoscience. Nicotine, the harms that we see, of course, with nicotine use in relation to tobacco use, of course, things like lung cancer, cardiovascular disease. But by no means would I tell people to start using nicotine. Nicotine is a useful tool in smoking cessation.
And when we're looking at the harmful effects of smoking,
Yeah.
is it mainly derived from the tobacco and not so much the nicotine? The nicotine is just used as the addictive part of it?
Yeah, so it's mostly from the tobacco and like the free radicals and all of this stuff. But, it's tough because a lot of the outcome data, like, do we have really long-term data on like nicotine use alone, right? Because nicotine's been used as a replacement. I actually don't know the answer to that.
Yeah. Because I've seen a lot of the discussion around nicotine.
I know. And all I can say for sure, unequivocally right now, is that the purported like claims of benefits of nicotine are way made up. And so the exact risks of nicotine on its own, I am not tremendously aware of the exact RCTs for that. But I know for sure that whenever I see these claims about the benefits of nicotine, they are ridiculous and they're not based on science. Whenever you double click into the studies, they're, that's one thing also, your listeners, when someone's making a claim, go look through this lens. Look, what kind of study is it? Is it in a mouse? Immediately delete and ignore. Is it in a cell petri dish? Ignore. Not to say that science ignores it. That's called preclinical research, and you base hypotheses on that, and then you have to study it in humans, in randomized studies. But, a lot of these claims are based on, or like an N of 10, not adequately powered randomized control trials. So, but yes, I would say that if there was one thing, reducing smoking, getting rid of smoking, completely getting rid of smoking, completely getting rid of vaping, and reducing, ideally, alcohol.
Do you drink at all?
I feel like with my elderly late 30s of age, it's like...
Elderly late 30s.
No, I feel like when I turned 30, I feel like maybe it's also medical training really takes a lot out of you, but I feel like that, like if I had a glass of wine, I would be like, okay. But then like every year, I feel like every year that I've like gotten into later in my 30s, like you have a glass of wine and then I have a headache the next day. So to be quite honest, I don't drink often, more because I do so much active stuff and therefore it would just impede in my routine.
Yeah. But do you see an issue with like occasional glass of wine here and there?
So yeah, well, great question, because we do have data on this. We used to say that moderate alcohol wine consumption is like beneficial, et cetera. No, so that's been completely, unfortunately, for the wine connoisseurs out there. Unfortunately, the data has shown us that actually no amount of alcohol is beneficial. It is all carcinogenic. It is all accelerates your risk for cardiovascular disease, increases your risk for high blood pressure, for atrial fibrillation. There's actually no marker in cardiovascular disease or even oncology that alcohol is beneficial for. That being said, we live in a world where saying everyone should be completely abstinent is so unrealistic, right? You have to meet patients where they're at. So for me, yes, I explain to patients. I also don't think we should lie to patients and say, oh no, drinking, this much is fine. I will say to them, listen, in an ideal world, we know that no amount is beneficial. But for you, if maybe even just decreasing 25% has a meaningful value for you, or 50%, depending on what that is, that is a benefit. So we do recommend reducing. Obviously, no alcohol is the goal, but we're also realistic. It's also like saying to someone like, you should have, there's so many things. It's all within the nuance, right? So just mentioning to someone that obviously, like, we're not going to say any amount of anything, like smoking is good, right? But if I can, ideally I get a patient to quit smoking completely, but if I can even get them at least to decrease their amount in the meantime, that's beneficial. But yes, unfortunately the alcohol one has been a change in the recommendations because there used to be a little bit of a gray area there, and now that's gone.
Can I tell you that since I started Tirzepatide, I just don't want to drink.
Isn't that fascinating? You are not the only one. It's like
I just
so many patients
don't
say
want to
that.
drink.
So many patients say that. And you know what's an added benefit of that? What I've seen with so many of my patients, it's fascinating, is that it's, I'm looking forward to eventually the trials and the information on, of course, people with substance use disorder, because I'm hoping, I believe it's being studied, and I can't wait to see what that data shows. But what's fascinating, even for people without substance use disorder, just patients that like casually have 2 glasses of wine a night or 3 glasses of wine a night, the amount of the improvement, like the fact that when they stop drinking and they're on, Zepbound or Mounjaro or any sort of GLP-1, and they're the improvement in their blood pressure, the reduction in atrial fibrillation, the improvement in all of their biomarkers from the reduction in alcohol. I mean, it's so tremendous. It's such a win. And, it's just great because it's not like you have to be someone that is, has like an official diagnosed substance use disorder to see that benefit. I'm seeing, at least anecdotally, from people who are just kind of those casual, quote unquote, social drinkers. And the fact that it's something that happens, it sounds like, at least anecdotally, that just happens subconsciously. You don't even have to think about it. You just don't want it.
At all. And we celebrate Shabbat every week, and typically you'll have a glass of wine on Shabbat, and like I'll put it out and I'll pour it, 1 or 2 sips. I'm just like, I don't want it.
Wow, what a win.
It's crazy.
What a win.
What
a win. Especially, and your blood pressure's killing it.
Yeah. Oh my gosh. Yeah. And then to see the ApoB improve.
Oh my gosh.
Okay, 3 more questions.
Yes.
So, and I asked this to any of the health people that come in here.
Yeah.
So when you're looking back on because you've done a lot of sports, you've done a lot of training. When you look at your life of training and workouts, what period of time in your life did you have your most fun with training? What was like your most fun, the best time period in your workout training life?
Man. Oh, that's great. I feel like sports, like organized sports.
Yeah.
I don't know if I'll ever get that feeling back as an adult, that like when you're like on a team and like you're young, so that's your whole life.
Yeah.
Like I did ODP, which was like Olympic Development Program for soccer. And I remember like, even though you're driving like 2 hours for the practice to meet like everyone in the region on your team, it's just like so fun. And it's just like your only like thing you're focusing on. Then as an adult, you have all this other stuff. But I would say besides youth, I would say, I think skiing. I think it's because for me, so I've always been a downhill skier. I downhill raced my whole life, downhill slalom. And then as an adult, I found that it's just, I love nature. I love being outdoors. And I just, I think one of the biggest gifts I got growing up was that I learned to ski when I learned to walk. So I don't ever remember not knowing how to ski. I think that if I was an adult with as much being a doctor, as much of risk aversion as I practice, I don't know if I would take up skiing as an adult. When I see adults learning to ski, I'm like, go you.
Yeah.
I give you so much credit, because the only reason why I'm not terrified is because I don't remember not knowing how to do it.
Right.
But I think that every winter season is just, I just love being outdoors and I love nature. And I think that especially if you do like off terrain and, there's of course risks with that, but I do the risk benefit ratio every time.
You got to live. You got to live.
There's
There's something about being on a mountain, snow coming down,
I love
fresh
it.
powder, and you find yourself just completely alone,
In the
looking at the
silence.
mountains. Silence
I
is,
don't wear headphones. Like I look at some of the kids these days. I
yeah,
sound like a boomer. I look at some of the kids these days, like with headphones, whatever. I'm like, I don't even need music or anything. I
yeah.
just like, it's just the
You just
most
hear
beautiful
the,
silence. And because it moves so fast, and especially if you're doing a challenging run, I love that your brain, you can't even think or worry about other things. I can't be thinking about, well, what's my office going to call? Did I finish this review? Like, what did,
yeah.
because you're like one wrong move when you're on double black, you're toast. So it's actually such a cool way that your brain just focuses on literal,
This moment,
this moment.
just this.
And it's because I found it's also to me, one of the best workouts because since actually a wrong move, you can die.
Hmm.
And you always wear a helmet when I ski. You actually will exert yourself to failure. I know I'm done skiing when I'm like, I cannot move. I cannot get back up on the lift again. Whereas like sometimes I'll phone it in when I'm working out. Just to know,
Yeah,
you know
yeah,
what I
yeah.
mean?
Nah,
If I
whatever.
can't
Yeah.
phone it in,
You got
that
to
way.
concentrate because you could have a serious issue.
Absolutely.
I love watching these young kids, like
Oh my
two,
gosh.
3, 4, and they just zip.
Zip. I
Zero
was
fear,
fearless.
zero
Yeah.
fear, just whoop. They go right by me. I'm like, oh my
Totally.
gosh.
Totally. When I was like 2, 3, oh my God, I was in ski. I was just going right down the mountain. I didn't make a turn.
Yeah,
I would just go straight down. And you're so close to the ground that when you fell, nothing really happened
that's a
anyway.
good point. That's a good
Now it's
point.
like the taller you are, the
Big
harder you
tree fall
fall.
hard.
Yeah,
Yeah.
yeah.
All right, 2 more questions. What are you scared of?
Am I scared of? I think as much as I have seen people die. I've seen gazillions of people die. I've watched people die. When you're a doctor and you're a cardiologist, you spend years and years and years in the ICUs. I've held people's hands when they die. I think when we get to the age where my parents are healthy and they're in their 70s, but, thinking of a time point where the people above you, like parents, even siblings and cousins start to pass away. I think that even though I've seen all of this death in my job, it's kind of like you become to some degree numb to it. But knowing that me, everyone listening to this, even if you're in your 30s or 40s, our families aren't going to live forever,
Hmm.
and the generations above us, and thinking of a life without them, that's probably my biggest kind of thing that I think of being a little scary.
Losing loved ones.
Yeah.
What are you excited about?
I am excited about the future of health and the way technology, as long as things continue to go in the right direction, the way technology can improve quantity and quality of life. I think already in our generation, we could very realistically expect to live to our hundreds and live well because if everyone gets their blood work done and checks their blood pressure, you could prevent a lot of cardiovascular disease. And so I think that, screening and things like that, getting a calcium score, if it's applicable to you, certain tests that we can use in cardiology to diagnose things early. I think that the treatments we have, it's like every decade, we're seeing not only just early diagnostics, but even better treatments, more efficacious treatments. I think that is the most exciting because I think it's that combination of living longer, but also living well. And I think that we have a lot of advancements going in that direction.
Danielle, thank you so much for coming on.
Well, thank you so much for having me. It was amazing. And thank you for being my inspiration to stick with my strength training because it's helped me to enjoy my other activities, which is a gift.
I love
Truly.
that. Where can people follow you?
At Danielle Belardo, MD, but on Instagram. And then I'm sometimes on, not really on X, but sometimes not really on Facebook much either. Really mostly on Instagram, Danielle Belardo, MD, except if you don't like seed oils and you are anti-sugar, feel free to just skip follow. It's okay. I just don't want to stress you out with my posts. If you recently bought a Parasite cleanse, I may not be the account for you.
Are you not doing podcasts anymore? You're on podcasts?
I loved podcasting. I had you on. It was one of my favorite episodes ever. But I just time-wise, I have my
Yeah, you're busy.
pause in so many things. And then my hobbies, it's like, it's just too much. But I appreciate you having it, and I appreciate being on and being able to, chat with you
No,
again.
thank you for coming. We'll put all of your information in the show notes.
Thank you.
Thank you, everyone, for listening. I hope you enjoyed the episode. If you did, please leave a 5-star review on iTunes, Spotify, YouTube, wherever you're listening. Please go follow Danielle. Again, all of her information is in the show notes. Have a wonderful week. We'll talk to you soon.